اتفضل.
اتفضل. اتفضل على طول دكتور محمد.
انا عايز اعمل شير بس انت مش مخليني اكتف ابلكيشن ويندو.
لحظة، لحظة بس. والله يعني ما نفهمش في الهوست تاعه. الدكتور محمد في جنبي هو التكنيكال.
الاستاذ اللي كان معايا امبارح يا فندم وعملت معاه. عليكم السلام ورحمه الله وبركاته. انا سامع حضرتك، اتفضل. جربتها يا فندم، انا فاتح الابليكيشن ويندو مش مدياني اي اكتف. الابليكيشن ويندو دي المفروض لما بكليك عليها وانا فاتح البرزنتيشن بيديهاني، اكليك عليها يديني الصفحه.
بالضبط.
طيب ده مش حاصل. لما بدوس انا حضرتك لما بدوس على الابليكيشن ويندو ما بيدينيش اي حاجه خالص.
اي حاجه خالص معناها ما تعرفش لو ممكن
نعم
تسكر البرزنتيشن حتى
نعم.
ممكن تسكر البرزنتيشن مرة ثانية.
حاضر
برزنتيشن
حاضر.
وليش ما يديش انتاير سكرين وخلاص؟
عملت كده برضو نفس الكلام يا فندم.
دكتور
نعم.
يور انتاير سكرين
اللي بيطلع لي فيها صفحه خاصه بيكم انتوا مش بيا انا.
هي يعرض على الجهاز. تمام تمام. انا حاليا بشوف ديسكتوب خاص بي. ممكن تفتح البرزنتيشن.
افتحها منين يا فندم؟
البرزنتيشن
طب ما انا
ايوه
فاتحها.
تمام. نشوف البرزنتيشن.
بس احنا ما دخلناش كده امبارح.
تمام. انت عندك مشكله في الصوت بس مش مشكله. تمام.
طيب اوكي.
لحظات نزل
يا بلال شريك.
لا لا مش على اللايف، مش على اللايف.
تمام دكتور. يلا. تمام دكتور. you can start now.
نبدأ.
Yes, you can start.
انا ممكن اعرف بس الاودينس معايا هنتكلم ارابيك فرانكو ارابيك ولا نتكلم ازاي؟
اتكلم زي ما يريحك دكتور.
لا يعني قصدي هل في معانا فورينرز يعني مش هيفهموا لغة عربية ولا موجودين معانا كلهم عرب؟
لا غير متوقع انه يكون معنا نون عربي،
تمام
كلهم عربي
تمام
اند انجلش سبيكينج.
تمام. طيب بسم الله الرحمن الرحيم. طبعا أنا بتشرف بدعوة الجمعية الليبية لأمراض الصدر على دعوتي إن أنا أكون موجود مع حضراتكم النهاردة، وبشكر لكم هذا المجهود والمهمة اللي أنا منوط بيها اللي هي هتبقى الكوفيد 19 مانجمنت أبديت. أنا اسمي محمد عبد الحكيم النادي، أستاذ بكلية طب قصر العيني كايرو يونيفرسيتي، وممبر of the COVID-19 Scientific Committee for the Egyptian Ministry of Health. ده اللوجو بتاع الكلية بتاعتنا Faculty of Medicine، وده اللوجو بتاع الجامعة بتاعتنا، ودي صورة القصر العيني الصرح الطبي اللي أنا بفتخر بانتمائي إليه. بحب دايما ابتدي الكلام بان الكوفيد 19 ميديسن اصبح طب دلوقتي، وتقريبا احنا بقالنا 10 شهور او داخلين على قرابة السنة بندرس فيه ولا نزال في بداياته، ولسه لا نعلم عنه الكثير. انا هتكلم على المانجمنت، يعني مش هتكلم على باثوجينيسيس ولا هتكلم على كلينيكال قوي. انا هتكلم هاو تو ريتش دايجنوزس، هاو تو ريتش اوبتيمم تريتمنت. ونسأل الله يعني ان الوقت يسعفنا في خلال النص ساعة دي. انا عايز اشخص عيان عنده كوفيد، يبقى لابد ان انا استعين بالكلينيكال مانيفستيشنز بلس البي سي ار او المسحه. يبقى انا بعتمد على الكلينيكال بتاعي بيبقى عباره عن عن بيجي سخن، بيجي بينهج، بيجي بكحه كحه جافه ولو انه ممكن تكون برودكتيف، وبيبقى لما بيعمل سي بي سي بيبقى معاها ليمفوبينيا، ممكن يلاقي فيه راديولوجيك ابنورماليتي او لا، لكن على مستوى الكلينيكال العيان بيبقى فيه عنده سخونيه وكحه جافه. اهم حاجتين بيميزوا هذا المرض السخونيه والكحه الجافه والنهجان. ممكن احيانا الم في الزور وتكسير وهمدان في الجسم. ودلوقتي بعض الناس بيتكلموا على اسهال وشويه مغص لو كان في عندي انتستينال افكشن. وبعض الناس الاخرى بتتحدث على فقد حاسه الشم والتذوق، لوس اوف تيست ولوس اوف سميل. يعني هو متعدد الاعراض، لكن اهم حاجه بالنسبه لي انا هي السخونيه والكحه والنهجان وفقد حاسه الشم والتذوق والاسهال والمغص. إذا وجد هذا الكلام على طول بشوف مين اللي متوفر عندي، هل هي المسحة ولا الإشاعة المقطعية لو كان في أعراض تنفسية. يبقى الأعراض بتاعتي بتتشخص مع المسحة أو مع الإشاعة المقطعية. مهم عندي هنا إن أنا ألفت النظر إن المسحة لما بتتعمل نيزل سواب ولما بتتعمل فارنجيال سواب. النيزل سواب الانسنس والبوزيتيفيتي بتاعتها 63%، ما معناه ان العيان ممكن يكون عنده كورونا واعمل له المسحه وتطلع سلبي. فلا ننخدع بهذا الكلام، احنا لازم نبص على العيان، لازم نبص على العيان ولازم نستيميت الكلينيكال بتاع العيان. طيب، البرونكو الفيولار لافاج يعتبر هو الجولد ستاندرد، لكن انا طبعا مش هقدر امشي على العيانين واعمل لهم كلهم مناظير واعمل لهم غسيل رئه واشخصهم، لكن هو اعلاهم في ان هو يطلع لي البوزيتيفيتي اب تو 93%. البال بيكون فيه ليمفوبينيا ودي فيري كاركترستيك للعيانين اللي عندهم كوفيد. والسي بي سي برضه فيري كاركترستيك ان انت تلاقي فيه العيان عنده ليمفوبينيا وبيبقى في عنده مايلد ثرومبوسايتوبينيا. طيب، يبقى احنا بنقول الاعراض مع البي سي ار او المسحه، او الاعراض مع الاتش ار سي تي، الهاي ريزوليوشن سي تي او الاشعه المقطعيه عاليه الجوده على الصدر. وبنقول ان احنا بنشوفها بتبقى جي جي او جراوند جلاس ابييرنس، وده معناه ان الالفيولاي بدات يبقى فيها فلويد بسبب الانفلاميشن. وبعد كده لو الفلويد دوت ملى الالفيولاي تماما يبقى في عندي سوليد كونسوليديشن. وبعد كده لو الانترستيشن حصل فيه سويلنج يبتدي يحصل لي اللي احنا بنقول عليه الكريزي بيفنج. يبقى الثلاث حاجات ممكن يكونوا موجودين مع بعض او ان ايزوليشن او اور ان كومباينيشن. الفيرست ساين اللي هي تبقى جي جي او، وممكن بعد كده يبقى في عندي كونسوليديشن، ممكن يبقى في عندي كريزي ليفنج. الحاجات دي فيري كاركترستيك ومعظم العيانين بتوعنا بنشوف فيهم هذا الكلام. بس بي كيرفول ان احيانا العيان ايرلي ان ذا ديزيز ما بيكونش لسه في عندي اللنج بقت بقت افكتد، وبالتالي ما تنخدعش وتقول طالما السي تي طالع نورمال يبقى العيان ما عندوش. لا، بننصح دايما ان السي تي لو هتعمله يبقى بعد 3 ايام من تاريخ ظهور الاعراض، عشان ندي فرصه ان السي تي يكون حصل فيه بعض التغيرات اللي هتساعدني في التشخيص. واتس اجينست ان انت تشخص ان العيان كوفيد لو ظهر لك في السي تي بايلاترال بلورال افيوجن، ولو ان ده اتعدل شويه دلوقتي، قالوا ان في بعض المرضى ممكن نعمل لهم الاتش ار سي تي ونجد ان في عندنا بايلاترال بلورال افيوجن مينيمال تو مودريت. طيب، هل الليمف نودز لو وجدناها دي بتسسبكت ان العيان عنده كوفيد؟ الاجابه لا. طب هل لو لقينا في كافيتيشن والساينز بتاعت الفانجل انفكشن هل دي تخلينا نسجست ان ده كوفيد؟ برضو الاجابه لا. يبقى انا في عندي حاجات مش ماشيه قوي مع الكوفيد لو لقيتها: لانج كافيتيشن، ميدياستاينال ليمف نود انلارجمنت، والبلورال افيوجن تراجعوا في هذه الاونه. اذا كلنا بنبقى قلقانين، وهنا بيقول له طمني يا دكتور، فبيقول له وانا مين يطمني؟ لان كلنا ممكن نكون احيانا انفكتد ومش ظاهر علينا اعراض، فبيبقى القلق سيد الموقف. لكن يهمني ان انا اقف على السلايد دوت وادي معلومات قويه عليه. لان البعض يقول له ايه، انا عملت صوره الدم والال دي اتش والدي دايمر والسيرم فيريتين والسي ار بي والاي اس تي والاي ال تي وطلعوا حلوين يبقى انا مش كوفيد، او طلعوا عاليين يبقى انا كوفيد. هذا الكلام عاري من الصحه. ليه؟ لان الانفستيجيشنز دي بتدينوت السيفيريتي، يعني لا تستخدم في التشخيص. امال تستخدم في ايه؟ تستخدم في البروجنوستيكيشن، يعني تقول للعيان ده المرض بتاعه سيفير او ليس سيفير، المرض ده هيبقى خطير او مش خطير. ليه بقى؟ لان احنا ما بنشخصش بالكلام دوت. امال بتعمل بيه ايه؟ بعمل بيه فولو اب. يبقى السي بي سي لما الاقي فيها ليمفوبينيا وتبتدي تتصلح يبقى العيان هيتصلح. ال دي اتش لما الاقيه عالي يبقى العيان دوت ممكن يخش في بوست كوفيد فايبروزس. الدي دايمر لما الاقيه عالي يبقى العيان دوت لايبل ان هو يخش في امبولايزيشن. لما يقيس السيرم الاقيه عالي يبقى السيتوكاين ستورم وارده. السي ار بي هو الفيرست انفلاماتوري سيتوكاين تو بي انكريز، وممكن ليتر اون لما العيان يبتدي العلاج يبقى ديكريزد. الاي اس تي والاي ال تي دول الليفر انزيمز وممكن يلاقيهم عاليين، وهكذا. يبقى اذا السيفيريتي بيتم تحديدها بالانفلاماتوري ماركرز ولا يتم التشخيص بها. امال التشخيص بيتم بايه؟ التشخيص بيتم بالاعراض مع المسحه او الاعراض مع الاشعه المقطعيه. اما دول الدي دايمر يقول لي هدي انتي كواجولانت ولا لا، السيرم فيريتين يقول لي هتحط السيروز ولا ما هتحطش، رايح لانفلاماتوري سايتوكاين ولا مش رايح لانفلاماتوري سايتوكاين. كويس. هنبتدي نتكلم على العلاج، وقبل ما اتكلم على العلاج لازم حضرتك تبقى ملم بهذا السلايد، وده بنسميه ماستر سلايد. يعني ايه ماستر سلايد؟ يعني من غيره مش هنقدر نفهم او نستوعب واتس بيهايند التريتمنت. بمعنى ان انا بقول لما العيان بيصاب بالكورونا او بالكوفيد بيبتدي يحمل جسمه بالفيرال مالتيبليكيشن، يبقى الفيز ده اسمه فيرال ريسبونس، وده بيستمر اب تو 12 يوم من تاريخ الاصابه. ايه اللي بيحصل فيه؟ الفيروس بيخش وينفكت السيل، ولما يخش وينفكت السيل ياخد الرايبوزومز بتاعتها ويصنع منها الار ان اي بتاعه ويبتدي يتكاثر وينفيد اذر سيلز. يبقى في الحته دي لو انت اديت انتي فيرال هيجيب نتيجه ونتيجه كويسه قوي. طيب بعد 12 يوم بيبتدي العيان ان هو يخش في واتس كولد هايبر انفلاميشن فيز. يعني ايه هايبر انفلاميشن فيز؟ يبتدي الجسم يرياكت للانفكشن بتاع الفيروس دوت ويطلع لي انفلاماتوري سايتوكاينز، لكن انفلاماتوري سايتوكاينز احيانا بتبقى طالعه بالزياده، ويبقى هو هنا عامل زي الدبه اللي قتلت صاحبها وما افادتوش كتير. فاحنا بنقول هنا لو انت حبيت تعالج بعد اليوم ال 12 يو هاف تو ماكسمايز الانتي انفلاماتوري عشان نقنن وضع استجابه الجسم للفيرال انفكشن اللي حصل في خلال ال 12 يوم اللي هم من تاريخ الاصابه. ان بتوين بقى ما بين الفيرال انفكشن وما بين الانفلاماتوري ريسبونس هيبقى في عندي اوفرلاب، اللي هو هيبقى في نيمونيك كونسوليديشن اللي احنا بنسميه كوفيد نيمونيا. الكوفيد نيمونيا في البدايه هتبقى وزاوت هايبوكسيا، وبعد شويه هتبقى كوفيد نيمونيا ويز هايبوكسيا، وهنا هيبقى الميكس بتاع الانتي فيرال مع الانتي انفلاماتوري له قيمه. يبقى اذا الرسالة اللي أنا ببعتها لحضرتك من هذا السلايد إن أنا بقول لحضرتك من تاريخ الإصابة إذا استطعت إن أنت تحدد بدقة، ينبغي عليك إذا كان في أول 12 يوم إن أنت تماكسمايز الأنتي فايرال تريتمنت، وإذا كان بعد 12 يوم يو هاف تو ماكسمايز الأنتي انفلاماتوري تريتمنت، وإن بتوين يو ار جاستيفايد إن أنت تحط الاثنين مع بعض. مين هي الانتي فايرالز اللي عندنا؟ الانتي فايرالز اللي عندنا كتير، كلهم نون سبيسيفيك عشان ما حدش يبقى زعلان. حتى هذه اللحظه حتى هذه اللحظه اواخر شهر 12 2020. هنبتدي بالهيدروكسي كلوريكوين، وزي ما حضراتكم عارفين بنبتدي القرص 200 مللي جرام، باخد قرصين كل 12 ساعه اول يوم، وبعد كده باخد قرص كل 12 ساعه لمده 5 او 10 ايام على حسب الريسبونس وعلى حسب البي سي ار هيقلب نيجاتيف ولا لا. يبقى ده اسمه هيدروكسي كلوريكوين. المحظور اللي عليه هنتفق ان هو بيعمل برولونجيشن للكيو تي انترفال. بعض الناس بره والدبليو اتش او قالوا في الاوت كام. انا بقول لحضراتكم على مستوى البروتوكول المصري وعلى مستوى علاجنا للمصريين لمئات الالاف من المصريين، لا هو جايب نتائج ونتائج كويسه جدا 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 جدا. تمام. تاني دواء اسمه الايفرميكتين، وده انتي سكيبز دراج وانتي انتي بارازيتيك، وده بيتاخد 6 مللي جرام. 6 مللي جرام بناخد 6 اقراص في اول ما بيجي لنا العيان اللي هو داي زيرو، وممكن نكرره بعد 3 ايام ونكرره كمان بعد 6 ايام. فالدوز بتاعتنا اجماليا هتبقى 36 مللي داي زيرو و36 مللي داي 3 و36 مللي داي 6. وهشرح لحضرتك بيشتغل ازاي لان الميكانيزم اوف اكشن بتاعه جميل. الفافيبيرافير ده 1600 مللي جرام، بعض الناس ممكن يدوه 1800، مفيش مانع. توايس ديلي، اول يوم بيتاخد مرتين، وبعد كده بيتاخد 600 او 800 توايس ديلي. الفافيبيرافير ده دواء ياباني، ميزته ان هو بيغطي الانفلونزا كما بان هو بيغطي الكورونا. فلو انت شاكك في العيان بتاعك هو كورونا ولا انفلونزا ولا الاثنين مع بعض، ممكن تدي الفافيبيرافير، بس بشرط الثلاثه دول لا يستخدم مايلد تو مودريت. لو مايلد بدل هيدروكسيكلوروكوين او الايفرميكتين، ولو مودريت بكومباين الاثنين مع بعض او بدي مكانهم الفافيبيرافير. بعد كده في عندي اثنين بقى انتي فايرال بحق وحقيقي بيشتغلوا عن طريق ان هم بينهبت الار ان اي ديبندنت بوليمريز انزيم، اللي هو اسمه الريم دي سيفير، اللي هي برضه طلعت الدبليو اتش او وقالت احنا بنصوت ضده دلوقتي في الاستخدام. ده بيتاخد 200 مللي جرام اي في، يعني اللودنج اول يوم، وبعد كده يبقى 100 مللي كل 24 ساعه لمده 5 ل 10 ايام. لو في 5 ايام ما جابش ريسبونس ممكن اكستند ل 10 ايام، وبعد كده ما بدهوش وما بزودش وما بطولش الفتره لو ما استجابش. اللوبينافير او الروتينافير اللي هو اسمه كاليترا او الالوفيا، وده انتي بروتيز، وده بيستخدم في علاج الايدز، وبنديه قرصين كل 12 ساعه 200 على 50، وبيجيب نتائج كويسه في العيانين المودريت تو سيفير او السيفير تو كريتيكال. واحنا بنقول ان الريمدي سيفير واللوبينافير والروتينافير بيستخدموا في العيانين السيفير والعيانين الكريتيكال. يبقى دول البوتنشال انتي فايرال. طيب اديني كده هنت سريعه على الهيدروكسيكلوروكوين. بقول لحضرتك ان الهيدروكسيكلوروكوين هو لما بنديه بيسمح للزنك انه يخش الخليه، والزنك لو دخل الخليه بينهبت الار ان اي مالتيبليكيشن بتاعها، وبالتالي يبقى الهيدروكسيكلوروكوين از ا زنك ايونوفور. كلوروكوين از ا زنك ايونوفور، يعني يسمح بدخول الزنك للخليه. هل ده الميكانيزم الوحيد اللي بيشتغل بيه؟ قال لك لا، لما بتدي الهيدروكسيكلوروكوين بيتشنج البي اتش اوف ذا، بيخليها مور الكالوتيك، وبالتالي بيخلي الفيروس كان نوت يوتيلايز اللايزوزايمز وما يقدرش يصنع منها البروتين بتاعه، وبالتالي يبقى بيعمل اندايركت انيبيشن للفيرال مالتيبليكيشن. طيب ادي الاوسيل تاميفير ولا لا، اللي احنا بنسميه تامي فلو؟ قال لك والله لا، احنا مش هنديه لو انت متاكد ان انت بتعالج كورونا. وفي بدايه المرض لما ظهر في الصين كانوا بيدوه لانه كانوا فاكرين ان هي انفلونزا، وبعد كده لما اكتشفوا ان هي كوفيد قال لك this agent has no role in the management of COVID-19 once influenza has been excluded. طالما انت قدرت تقول ان هي دي مش انفلونزا يبقى الاوسيل تاميفير ملوش قيمه. طيب الايفرميكتين ده، الايفرميكتين ده انت عمال بتقول لي ده انتي بارازيتيك وانتي هيلمنثيك وانتي سكيبز، طب انت بتديه ليه؟ عشان تعالج بيه كورونا. قال لك والله الايفرميكتين ده بيمسك في الامبورتين الفا وبيتا اللي هم مسؤولين عن عمليه نقل الفيروس لداخل الخليه. ادي الامبورتين الفا وبيتا بيمسك فيهم الكورونا فيروس ويتنقل عن طريق نيوكلير بور كومبلكس ويروح للخليه ويمالتبلاي. لو انت اديت الايفرميكتين بدوره بيمسك في الانفورتين الفا وبيتا، وبالتالي الكورونا فيروس ما يقدرش يخش، وبالتالي يبقى الايفرميكتين ده سيف اندايركت انتي فايرال. ليه بقول سيف؟ لانه بيستخدم من زمان، واخد اف دي ابروفال في علاج الايه الامراض اللي احنا اتفقنا عليها دي بارازيتك. كويس قوي. يبقى الايفرميكتين ده دواء كويس ورخيص وبيساعدنا وبيجيب نتائج هايله، وزي ما اتفقنا 6 اقراص 3 مرات، 6 اقراص على 3 جرعات، دي 0 ودي 3 ودي 6. وادي الطريقه اللي احنا اتفقنا عليه ان هو بيشتغل بيها، ان الايفرميكتين بيمسك في الامبورتين الفا وبيتا، وبالتالي يبقى النيوكلير بور كومبلكس ما يقدرش يدخل الكورونا فيروس لداخل الخليه، وبالتالي ما تقدرش تعمل مالتيبليكيشن. كويس قوي. يبقى انا كده اتفقت مع حضرتك ان احنا ازاي هنعظم دور الانتي فايرال في بدايه الانفكشن في خلال اول 12 يوم، وكل على حسب درجه خطورته. لو كان مايلد تو مودريت هاخد الهيدروكسيكلوروكوين والافرمكتين والافيجان او الفافيبيرافير. لو كان سيفير تو كريتيكال هاخد الريمدي سيفير او الايه اللوبينافير روتينافير. طيب نيجي لتاني اللي هو اسمه بكتيريال كو انفكشن وسكندري انفكشن ان بيشنت ويز كوفيد. وهنا لازم الفت نظر حضرتك ان الانتي بيوتكس احنا لما بنديها بيبقى لينا 3 نيات مع بعض. ممكن اديه ويشتغل كانتي بيوتك، وممكن اديه ويشتغل كانتي انفلاماتوري اميونو موديولاتري. كويس قوي. يبقى انت هنا هتدي ليه؟ تقول لي والله اول حاجه انا شاكك اللي عنده بكتيريال نيمونيا. تقول لي هو بكتيريال ولا فيروس؟ اقول لك كومباينيشن، كو او سوبر ادد انفكشن. هشك امتى في العيان ان عنده كو انفكشن او سوبر ادد انفكشن؟ تقول لي والله العيان بتاعي كان كويس وعملت له انفستيجيشنز وكانت حلوه، بس لقيت السي ار بي بعد ما كان نزل لقيته طلع، او عملت واي بي سيز لقيتها عاليه ومعاها شيفت تو ليفت او توكسيك جرانيوليشن، او لو كان العيان ما عندوش حراره وبدات تظهر له بعد كده، او لو قست البروكالسيتونين ولقيته عالي، او لو كان الباترن بتاع الكونسوليديشن بايلاترال الفولار سوليد كونسوليديشن راذر ذان جراوند جلاس اوباستي واخد اكتر من 50% وفي رابيد ديتيريوريشن، يبقى في الحاله ديت انا بشك ان العيان بتاعي معاه كومباينيشن ما بين الكوفيد وما بين الايه السكندري بكتيريال انفكشن. يبقى لو سمحت سؤال مهم، لو هتدي انتي بايوتيك هتديه ليه؟ تقول لي والله انا ممكن ادي الانتي بايوتيك لانه هو اميونو موديولاتري انتي انفلاماتوري، وممكن اديه عشان العيان عنده بكتيريال نيمونيا. تشك ازاي ان العيان عنده بكتيريال نيمونيا؟ تقول لي والله في عندي رابيد كونسوليديشن، رابيد ديفلوبمنت اوف كونسوليديشن، او لوبر كونسوليديشن، او ليوكوسايتوزس، او وجود الحراره، او زياده السي ار بي بعد نزول الفيرتين او البروكالسيتونين اس2 ولقيته عالي. تقول لي طيب حكايه انتي انفلاماتوري اميونو موديولاتوري دي مين بيتميز بيها عندنا؟ اقول لك 4 جروبس. واحد ليفوفلوكساسين والموكسيفلوكساسين يبقى دي الكينيلون. اثنين الماكرولايت جروب اللي هي الازيثرومايسين والكاليريثرومايسين. ثلاثه الدوكسي سايكلين. اربعه الاوكسيزوليدينون اللي هم اللينزوليد اللي احنا بنتكلم عليه بيشتغل معايا. هو بيشتغل على المرسى، لكن انا لما بديه هنا مش بديه عشان هو بيشتغل على المرسى، لا انا بديه عشان هو انتي انفلاماتري اميونو موديولاتري. يبقى لو انت هتدي ومش قلقان ان في سكندري بكتيريا انفكشن اختار من الاربعه. طب لو قلقان يبقى هتتعالج كما لو كنت بتعالج نيمونيا مع كوفيد، بكتيريا النيمونيا مع كوفيد. هتدي امبيريكال تريتمنت؟ قال لك مفيش حاجه اسمها امبيريكال تريتمنت، لازم تشخص. امبيريكال انتي بايوتيك هتتاخد في علاج النيمونيا اللي هي الكاب كوميونتي اكوارد نيمونيا، هي كما لو كان عنده كاب نيمونيا ويز كوفيد. relevant bacterial pathogen in patient with pneumonia and COVID are likely the same زي النيمونيا without COVID. يبقى احنا مش هنغير كتير في العلاج. يبقى هنا بنسأل نفسنا لو كان العيان لو ريسك ولو كان هاي ريسك، وانا عايز الاجابه ببساطه. لو انت هتدي انتي بايوتيك والحاله سيفير تدي كومباينيشن من بيتا لاكتام مع ماكرولايت او بيتا لاكتام مع كينيلون، سهله جدا. طب ولو كانت لو ريسك هتدي مونوثيرابي، ممكن فلوروكينيلون كفايه قوي، ليفو او موكسي، او كومباينيشن ثيرابي بيتا لاكتام بلس ايزر ماكرولايت او دوكسي سايكل. يبقى لو انت هتعالج هتدي انتي بايوتيك، لو سمحت تسال نفسك سؤال، العيان بتاعك لو ريسك ان بيشنت ولا هاي ريسك؟ من الاخر كده انا بدي بيتا لاكتام مع ماكرولايت او بيتا لاكتام مع كينيلون لو هاي ريسك. طب لو هدي مونوثيرابي فلوروكينيلون ريسبيريشن بيتا او بيتا لاكتام مع دوكسي سايكل. كويس. يبقى انا كده وضحت لحضرتك دور الانتي بايوتيك. الانتي بايوتيك اللي بنكتبها عماله على بطال، لو هتكتبها ومفيش بكتيريال انفكشن يو ار جاستيفايد تختار من الاربعه اللي انا قلت لحضرتك عليهم، اللي هم الكينيلون او الدوكسيسايكلين او الاوكسيزوليدينون. طيب لو عايز تدي كانتي انفلاماتوري بقى، خلصنا ال 12 يوم او في الجاب ما بين ال 8 لل 12 ورايحين لما بعد ذلك وداخل العين مني في سيتوكاين. سيتوكاين يعني معناه ان الاميون سيستم بتاعي جامح زي جموح هذا الحصان ويحتاج الى ترويض. ليه؟ لان لو سبته ممكن يبقى عامل زي الدبه اللي هتقتل صاحبها، لانه بيرش انفلاماتوري سايتوكاينز بكميات عاليه ورهيبه، فممكن يبقى الريسبونس بتاعي ان العين يخش في مالتيبل اورجان ديسفانكشن ومالتيبل اورجان فيلير، والنهايه تبقى ميكانيكال فنتيليشن والقصه اللي حضراتكم عارفينها. اذا الاميون سيستم بيرد بهذه الصوره، مش عارفين نحجمه، لكن احنا عايزين نوصل لدرجه ان احنا نقدر نمتطيه ونؤهله لوظيفته ان هو يساعدنا ولا يكون ضارا بنا. مين الدوايين المسؤولين عن تقنين وضع الاميون سيستم؟ هم دوايين ما لهمش ثالث، الكورتيكوستيرويدز والتوسيلوزيوماب او الانتي انترلوكين 6 اللي احنا بنسميه الاكتمر. كويس قوي. الاستيرويدز مهمه جدا في الكوفيد 19، وزي ما اتفقنا يتعاظم دورها بعد اليوم ال 12 وان بتوين ما بين اليوم الثامن لليوم ال 12 لو كان العيان دخل فيه الكوفيد نيمونيا، سبيشالي لو كان معاها الهايبوكسي. طيب طلعت علينا الاوكسفورد وقالت لك احنا اكتشفنا دواء جديد بينقص المورتاليتي، وايه هو الدواء ده؟ قال لك ده الديكساميثازون. طبعا نصابين، وكانت البيبر بتاعتهم ستون تو بريفنت ديسز. احنا من زمان واحنا بنديه، وكلنا يعلم كويس قوي ان العيانين الكريتيكال حتى لو هم ما عندهمش اي مشاكل بنحط الاسترويدز، خصوصا لو كنت كفرنج بالانتي بايوتيك والانتي فايرال، وبالتالي ما فيش مشكله هنحط الديكساميثازون عشان يحدد لي الريسبونس بتاع الاميون سيستم. ويمكن البروتوكول المصري كان له السبق في هذا الكلام، حاطينه من بدري الايه الاستيرويدز ميثايل بريدنيزولون 1 ل 2 مللي بير كي جي. لو كان نون فنتليتد بندي 1 مللي، ولو كان فنتليتد بندي 2 مللي بير كي جي ان تو ديفايدد دوزس. ومعايا التوسيليزيوماب زي ما حضراتكم شايفين كده، وده بيتم في كل العيانين اللي الريسبيراتوري ريت فيهم بيعدي 30 او الساتوريشن اقل من 93 او البي او 2 على الاف اي او 2 اقل من 300 او الاكس راي فيها اكستنسيف شادوينج اكتر من 50% على مدار 48 ساعه، او لو كان العيان كريتيكالي ال ومحتاج هذا الكلام على فنتليشن. لكن المهم هنا ان حضرتك تبقى عارف ان الجلوكوكورتيكويد ايكويفالنت دوز. يعني ايه ايكويفالنت دوز؟ يعني عندي الهيدروكورتيزون ال 20 يساوي 25 كورتيزون، يساوي 5 بريدنيزولون، 4 ميثايل بريدنيزولون، 4 تراي امسينولون، يساوي 0.6 بيتا ميثازون او 0.7 ديكسا ميثازون. هذا الكلام مهم ليه؟ لان احيانا بنحول من دوز لدوز، احيانا بحول من ميثايل بريدنيزولون الى ديكسا، او من ديكسا الى ميثايل بريدنيزولون، فبقى محتاج اعرف الايكويفالنت دوز. وهنا بيوريك قد ايه ان كل واحد، اللي هو البنفسجي الاولاني ده شورت اكتنج بيختفي على طول من الجسم، وانترميديت اكتنج اللي هو لونه لبني، واللي لونه احمر دوت اللي هو اللونج اكتنج. فلازم تبقى عارف ايه الراشونال من الانتي انفلاماتوري كورتيكوستيرويدز اللي انت هتديها، وعايزه تقعد فتره طويله ولا قليله، ولما تيجي تقلبها على حاجه اقل تبقى تقلب بايكويفالنت دوز قد ايه. فالسلايد ده مهم جدا يا جماعه نبقى عارفين. وفي برامج كتير جدا بتقول لك لما تيجي تحول من كذا لكذا تدي كذا يبقى ايكوفالنت ليك، وبهذه الصوره. يبقى ده اول دواء من الانتي انفلاماتوري اللي هو الكورتيكوستيرويدز. ثاني دواء وبنحبه قوي وجايب معانا نتائج كويسه قوي اللي هو اسمه التوسيليزيوماب. والتوسيليزيوماب يا جماعه كويس جدا في ان احنا نستخدمه، بس لازم يكون في مكانه. يعني ايه في مكانه؟ يعني ما تجيش تقول لي واحنا في الايرلي فايرال فيز والدنيا فيها فايرال مالتيبليكيشن ومعاه سكندري بكتيريال انفكشن انت عايز تدي الاكتامر. غلط. امال اروح له امتى؟ هتروح له في الفتره ما بين اليوم الثامن لل 12 او ما بعد ال 12، بالذات لو كان العيان بتاعك بيديتيريوريت ان سبايت اوف يوز اوف انتي انفلاماتوري كورتيكو استرويدز. يهمني في ان هو بيدركني لو كان في عندي السيتوكاين ستورم. احنا عندنا فيلم كده باللغه العربيه بتاع عنتر بن شداد ده بيقول له ادركني يا شيبوب، فمن هنا هيدرك شيبوب هيدركه بايه؟ هيدركه بالتوسيلوزيوماب ويجيب معانا نتائج كويسه. خد بالك بقى، لو اديت الانتي انترلوكين 6 بدري ده هيزود المورتاليتي وينقص الفاجوسيتوس بتاع الماكروفيج وينقص الهيلينج، يبقى انت اذيت العيان. لكن لو اديته في ميعاده هينقصك المورتاليتي وهينقصك اللنج انفلاميشن. وبالتالي يبقى ايه؟ ان كل شيء خلقناه بقدر، هنخلقه بحساب ويتحط بحساب، زي ما ربنا سبحانه وتعالى علمنا دايما ان كل حاجه لما تتاخد بقدر تبقى ماشيه مظبوط وتمام. يبقى انا كده قننت لحضرتك الوضع بتاع استخدام الانتي انفلاماتوري سواء كورتيكوستيرويدز سواء توسيلوزيوماب. بعد كده هخش على
عفوا
انتي.
بعد إذنك دكتور محمد we only have 5 minutes for the presentation بعد إذنك.
تمام اوكي يا فندم. الانتي كواجلنت احنا بنقول هندي ايه؟ انتي كواجلنت هندي ولا ما هنديش؟ هندي الانتي كواجلنت. هتديها ازاي؟ والله انا بديها على حسب العيان بتاعي. لو بي دي ساتوريت او تاكيبنيك او على روم اير يبقى انا في عندي الانسنس بتاع الامبولايزيشن عالي 40 او 50% منهم بيجي لهم بالمونري امبوليزم. يبقى لازم ناخد بالنا ان انا بيبقى في عندي اندوثيليوباثي ومايكرو انجيوباثي. الاثنين دول مسؤولين على ان انا ادي للعيان انتي كواجلنت عشان اقدر احافظ عليه. اخد بالي ان انا مش بدي الانتي بليتلت ولا بدي ثرومبوليتيك ثيرابي، انا بدي الانتي كواجلنت. والانتي كواجلنت في منهم اثنين، يا اما بدي الدو اكس او بدي الفوندا بارانوكس، لكن يفضل ان انا ادي لو موليكولار ويت هيبرين لو كان بروفيلاكتيك في الاي سي يو. لو كان ثيرابيوتيك بدي برضو اللو موليكولار ويت هيبرين. ممكن ادي الاورال ريفاروكسابان او الابيكسابان او الدابيجاتان، ودول بيتاخدوا لو كان العيان في البيت او لو كان قاعد في مستشفى في اوضه عاديه. يبقى اذا انا كده تقريبا خلصت. بقول لو كان في عندي العيان عنده نيمونيا ودخل الاي سي يو لازم افرق هو تايب ال ولا تايب اتش. تايب ال ده بيبقى له الاستنس وبيتحط على ميكانيكال فنتيليشن من غير بروتكتيف فنتيلاتوري استراتيجي، ولو كان اتش بنستخدم فيه البروتكتيف فنتيلاتوري استراتيجي. طيب نيجي بقى لاخر 3 سلايدز اللي هم ايه. بيقول لو انت عندك مايلد كيس، انا لسه قايل دلوقتي الهيدروكسيكلوروكوين او الايفرمكتين، واحط معاه الزنك والاسيتالسيستين واللاكتوفيرين وفيتامين سي. لو كان مودريت باخد الهيدروكسيكلوروكوين ومعاه اللوبينافير او الروتينافير، يا ده يا ده، الهيدروكسيكلوروكوين والايفرمكتين او اللوبينافير روتينافير او الريمديسيفير لو كان هيقلب مني على سيفير. واحط معاه الاستيرويدز وكونسيدر الانتي كواجولانت لو كانت دي دايمر اقل من 1000 تبقى بروفيلاكتيك، ولو كان اعلى من 1000 يبقى ثيرابيوتيك. لو كان سيفير هادمت في الاي سي يو واخد الريمديسيفير واللوبينافير زي ما اتفقنا، واحط الانتي كواجولانت على طول، واحط الاسترويدز، واحط التوسوليزيوماب، وكونسيدر الكونفاليسنت بلازما. واخر سلايد الكريتيكالي ايه البيشنت، هحط معاه الانتي فايرال وهحط معاه الانتي كواجولانت وهحط معاه الانتي انفلاماتوري. وفي النهايه بقول ان الموضوع يا جماعه لسه لا يزال it is a baby disease. كلنا في انتظار ان احنا نعرف الدنيا ماشيه ازاي، نحط جايد لاينز ونحط كونسنسس ويبقى فيها معاه ايفيدنس بيزد ميديسن. وبالتالي مش هننكر قوي على بعض الناس بتستخدم ده او ما بتستخدمش ده. all recent study showed that all recent studies are false. ده وارد ان احنا نصحى الصبح تاني يوم نلاقي هذا الكلام متغير، لان حتى الان we are gaining experience we are gaining knowledge about الكوفيد، ولسه لم تكتمل الصوره بدرجه واضحه. بشكركم على حسن استماعكم وأتمنى أكون أضفت لكم، وشكرا جزيلا.
شكرا جزيلا دكتور محمد for an excellent presentation. احنا نسينا ونعتذر ان نعزوك في الوالد، ف عظم الله اجركم واخلفكم البركه.
آمين يا رب العالمين، جزاكم الله خيرا.
طيب unfortunately I think we only have a few viewers online. I think we may have about 30 in total. So I think يعني للأسف ما عنديش أي أسئلة دكتور محمد. ممكن سؤال وحيد اللي هو أنت حكيت عن الهيدروكسي كلوروكوين، فإذا كان هو فيه any data local data من مستشفيات في مصر ممكن تعطينا فكرة عليها يعني.
هو احنا في عندنا حضرتك في عندنا 2 ترايلز في مصر وعاملين لهم سبمشن دلوقتي، والمفروض ان احنا ويتنج الاكسبتنس بتاع النشر بتاعهم.
طيب جميل. We look forward to seeing these
ان شاء
trials.
الله ان شاء الله.
طيب we move on to the next speaker who's Dr. أنعم العربي أو عربي. أنا مكتوب عندي العربي أنعم.
السلام عليكم.
This is
العربي.
going to be GINA 2020, the fate of steps 1 and step 2. طيب the floor is yours دكتور أنعم.
السلام عليكم ورحمة الله وبركاته. I just put it on full screen. Can you hear me? السلام
Yes,
عليكم.
nice and clear.
Yet have to see my slides. All right. Can you hear me and can you see me?
We can see you. No, we can't see you. We can see your full screen.
Yes. All right. That's more important. السلام عليكم ورحمة الله وبركاته. طبعا اسمي أنعم العربي. Actually, I'm honored to present in the first international virtual conference on obstructive lung diseases hosted by the Libyan Thoracic Society. I wish you all the luck with the further presentation that you had, and I admire your great job in this difficult time. I have no disclosure. The outline of my presentation, I will touch briefly about the introduction about the GINA, what's the GINA, the history, the structure, and the advantages it provides over the common and well-established guidelines. We'll touch also about the recent shift in the GINA recommendations, particularly regarding the mild asthma patients, particularly step 1 and 2, the reasons and evidence behind the awaited changes in the asthma management. So what's GINA stands for? It's a global initiative on asthma. It's actually a strategy document rather than a guideline, and it updates its evidence annually based on research published in the previous year. And in case if there is any new therapy, it needs at least approval by one of the major regulatory agency, either the EMA, European Medicine Agency, or the FDA. The target population, most physicians who are dealing with bronchial asthma resistance, as well as specialist respiratory physicians dealing with severe asthma patients. So since it was launched in 1993, GINA has long recommended SABA as the first line of asthma treatment. Not only GINA, but all the guidelines, and this dates back to the 1960s when asthma was thought to be a bronchoconstriction disease rather than inflammatory. It's not up till recently when the changes happened in 2019 and 2020 where the shift has changed in the early management of asthma. Surprisingly, the BTS actually released their revised edition of guideline in 2019 July. They still recommend SABA as the first line treatment for all patients with symptomatic asthma. They do also recommend that preventer of steroids, inhaled steroids, can be, or this is the recommended actually prevent drug for treatment of patients with adults and patients with them to achieve the overall treatment goals. Regarding GINA, in 2018, we can see clearly that step 1 had no preferred agent to be used. So we used to rely only on SABA as preferred treatment as a reliever. So we don't have a preferred controller at that time. Okay, so for step 1, it's indicated for patients who have symptoms less than twice per month, and they have no risk factors for exacerbation. And by risk factors for exacerbation, I mean if they have any uncontrolled asthma in the past, if they have smoking, if they have allergen exposure, air pollution, obesity, or high SABA use. But we notice that the risk of mild asthma, since mild asthma contributes a huge bulk actually of the total patients of asthma, up to 75% of asthma patients, according to a study done in 2007. It's a retrospective multi-center trial looked at the mild asthma patients, but they found that mild asthma patients contribute to 30 to 37% of acute asthma attacks, 16% of near-fatal asthma attacks, and 15 to 20% of adults dying of asthma. These are patients who are, we thought that they are mild asthma, so we thought that they are at lower risk of having a severe exacerbation or even simple exacerbation. Furthermore, these are the patients who were on SABA only. SABA only treatment has been found to have a lot of adverse effects if you rely only on SABA. One of them is decreased beta receptor degradation, which means there is a decreased bronchodilator response with the excessive use and rebound hyper responsiveness sometimes. They also had found in another trial that there is increased allergic response and increased eosinophilic airway inflammation. I will show you in a slide later. Higher use of SABA actually is also associated with higher morbidity and mortality. And this is taken actually from a retrospective trial. They saw that the patients who took more than 3 canisters per year, they are associated with higher emergency department presentation. And if more than 12 canisters per year, they have a higher risk of mortality. So this is the study that associated terbutaline, which is a SABA, with the excessive airway inflammation. Looking at the sputum eosinophils over here, the terbutaline group had a higher sputum eosinophil levels as compared to the patients who were on ICS, budesonide, or combined acidonis with SABA. And we also know that severe exacerbations leads to decline in lung function, and the use of budesonide is also associated with attenuation of this decline. So since we know all these studies since 10 or 20 years about the risk factors and the adverse effect, GINA committee has been seeking actually or sought a proper randomized control trial to prove that ICS is superior at least to the SABA use, or at least non-inferior. So this was resulted in the release of the 2 famous SIGMA trials. We'll start with the SIGMA 1. They had actually 3 groups. It's a randomized trial. We have 3 groups actually of terbutaline as needed, or budesonide formoterol as needed, or budesonide maintenance. So what they found is that the budesonide formoterol has been obviously superior to the terbutaline or the SABA group in terms of reducing asthma exacerbation as well as reducing symptoms. By asthma exacerbation, I mean severe as well as non-severe exacerbation. The SIGMA 2, they had actually 2 arms. The first arm is a budesonide formoterol as needed, in addition to twice daily placebo. And the second arm is a budesonide only constant dose, as well as needed terbutaline. And what they found is that the budesonide formoterol as needed was non-inferior to twice daily budesonide in dealing with the rate of acute, severe exacerbation. So we can rely on budesonide formoterol as needed because it's non-inferior here as compared to fixed dose of budesonide. But was actually inferior a little bit in the controlling of symptoms. Just to highlight here, what they found also is that the patient who were in the budesonide formoterol as needed arm has used the steroids only in 25% of the amount that the other group has used. So significantly lower exposure to steroid as compared to the other arm. Then we had the trial, which was actually also published in the New England Journal of Medicine in 2019. Actually, it results to the same, it gave us the same results, but it added that the budesonide formoterol group as needed, as compared to maintenance, was superior actually in the number of severe exacerbation. And obviously, the number of severe exacerbation and the annual exacerbation rate was superior to terbutaline. And this was the target or the primary aim of the study, is to compare to the SABA. Now, what we know is that since asthma is an inflammatory condition, we should always use an anti-inflammatory medication. So, and we also know that the asthma, bronchial asthma, is a wax and wane disease, which the patient will have like period of months of exacerbation or higher inflammation, and periods in which like the disease is waned and the disease is under control without the need of steroid. So some experts actually asked the question, so since it's an anti-inflammatory condition, why we don't use the budesonide maintenance group continuously to control this. So they added another results in this trial, and they compared these two groups. They found that FeNO has been compared between these two groups on constant budesonide as compared to the as needed budesonide formoterol, and they found that they have similar FeNO level. And this was actually justified by the patient when you give him the option of using one inhaler as needed, and you give him the SMART technique and explain it well. So whenever the patient feels that his symptoms are getting more and more, he's having more cough over the day, maybe disturbed a little bit overnight with chest tightness and wheeze. So whenever he increase the dose of, this is what's actually happened. So you give him the option, flexibility of increasing the dose up to 6 or 8 times of the low dose ICS-LABA. So it leads to a better control of the disease and less exacerbation and control of inflammation. All right, so the slide was taken from the GINA 2020. As we see, as we compare to the previous slide, now in the step 1, they recommend now the peripheral controller, which is as needed low dose ICS formoterol, okay, instead of just leaving them for short-acting beta agonist. And the peripheral reliever is ICS also formoterol with the MART technique. Now for step 2, since we found also that daily or as needed ICS-LABA, ICS formoterol is non-inferior actually to the fixed dose, recommended as the first-line treatment. You can give the patient the option, and he can definitely choose. So just to summarize what I said, so GINA actually no longer recommends SABA-only treatment for step 1. Every patient with asthma should be on ICS containing controller treatment to reduce the risk of serious exacerbation. This can be as a regular daily treatment or as needed low dose of ICS formoterol. And with this, I conclude my slides and my presentation. Open for any questions, Dr. Anas.
Thank you so much, Dr. Anam, for such a fantastic presentation. So I have one quick question. So patients with enough symptoms to suggest they should go on step 2, in other words, low dose ICS and SABA. Now, we know that Sigma 1 and Sigma 2 recruited patients from step 2. The question is, these patients, and in real life, would you say to them that they can stop? And we're talking about step 2 patients. Would you say to them that they could stop regular ICS and just move on to a SOS LABA ICS?
Yeah, thank you for the excellent question, Dr. Anas. Actually, we encounter such patients a lot after, especially after the release of the trial. So it depends on what kind of inhaler they have been using, and are they comfortable with it or not. And we know we rarely see physicians who are stepping down a treatment. We usually fix the patient on our comfortable regimen, although the GINA recommends reviewing every 3 to 6 months, and depends on the symptoms and maybe even the spirometry. You may consider stepping down, and I actually encourage this, although it's not commonly practiced. So it depends on the inhaler that has been used with the patient, and it depends on the control over the last 3 to 6 months. If the patient does not have any exacerbation and does not have any risk factor for severe exacerbation, I would definitely strongly recommend shifting the patient to ICS formoterol, especially with the available evidence that we have now.
Right, fantastic. So I'm just looking at the YouTube link. I can't see any questions. So I think we will move on to the next speaker. Thank you very much, Dr. Anam.
Thank you. I'm honored and delighted to have such an opportunity to be with you guys. Thank you.
How many professionals are necessary to make more than 100 crucial decisions daily? How many scientists are necessary to develop more than 500 new scientific researches? How many experts are necessary to develop and train new talents joining our company day after day? How many qualified people are necessary to ensure the quality and safety of more than 300,000 boxes of medicine produced every day? We are thousands of employees who understand the criticalness and necessity of medicine in your life and in the lives of your dear ones. Our objective, contributing to the health and well-being of 400 million Middle Easterners, 700 million Africans. Eva Pharma, securing your health.
his apologies for not appearing. I think he had problems with internet connections, just like we have here in Libya. So his original talk was going to be optimal asthma management in children between 11 o'clock and 11:30. So unfortunately, we are very sorry to lose the benefit of listening to that fantastic talk. So I'll leave the floor to Dr. Husniya Sudani, common medicines used in obstructive lung disease.
Assalamu alaikum. It's my pleasure to share in the conference Dr. Husniya Sudani, medical specialist in University Tripoli Hospital, to present the Aldo-Union products which are commonly used in obstructive lung disease. الخبرات الدوائية for pharmaceutical and medical supply company is dealing with a private company based in Tripoli, Libya. We were established in 2017 and supply both private and public sector in the field of medical supply. الخبرات الدوائية dealing with well-known laboratories gaining excellent marketing of different regions in the country, depending on our appointed distributors in many towns, in addition to well-qualified medical reps for promotion. Aldo-Union was founded as a pharmaceutical laboratory in Spain in 1961 by Mr. Jose Caldaza, doctor of pharmacy. Aldo-Union was also the first company in the world to commercialize and as a medicinal product. From the point of view of research, its activity has also been carried out in the synthesis of non-steroidal anti-inflammatory drugs and in the development of ethical preparation commercialized in the form of syrup, tablet, and nebulizers. One of our production due to asthma is salbutamol aerosol, is a bronchodilator selected for beta-2 receptor, which are predominantly a receptor in the bronchial smooth muscle, make relaxation in the smooth muscle of the airway. Mechanism of action, due to asthma and other beta-2 agonists are increase the conductance of channels sensitive to calcium and potassium ion, leading to a hyperpolarization and the relaxation of bronchial smooth muscle. The dose of due to asthma, the package of container comes in 200 doses, 100 microgram, mainly indicated in relieving bronchospasm due to any cause. Also used in acute and chronic asthma. Also used in prevention of exercise-induced bronchospasm, and also in chronic obstructive airway disease. Due to asthma, produce bronchodilation within 5 minutes and lasts up to 2 to 4 hours. In adults and children, it's used to relieve bronchospasm and treat the of bronchial asthma, used when needed, 1 puff as a single dose, and the maximum dose of due to asthma should not exceed 12 puffs per day. In order to prevent exercise-induced bronchospasm, 1 to 2 puffs should be used 15 minutes before exercise. The second product is Beclo-Asthma, is well known to us. It is betamethasone dipropionate, is powerful glucocorticoid and have a strong anti-inflammatory effect, and it does not have any severe systemic side effect. It's available in metered dose inhaler and used as prophylactic treatment in bronchial asthma. The size of particles is smaller than 5 micron, and the container comes in 200 doses, 250 microgram per dose. The indication, it is used in most of asthmatic patients once the patient exceed the maximum dose of bronchodilator, and used also in acute bronchial asthma following the dose of oral corticosteroid. Also used in COPD in gold grade 3 or 4 and group C and D to prevent the further exacerbation, and also used in bronchiectasis. The dose used 2 puffs twice a day, and it can reach up to 2 puffs per 4 times a day. Maximum dose up to 2,000 microgram per day. The patient should be warned that the treatment with bicular asthma is prophylactic. So the patient should be regular in his medication and not using it just to relieve the symptom. Another preparation is formoterol. Formoterol fumarate comes in dry powder capsule, inhalation with aerosol. Capsule is 12 microgram. It is long-acting beta-2 agonist, known as LABA, used to control asthma and COPD. Formoterol has unique characteristic of rapid action and sustained effect reached up to 12 hours duration, compared with the other bronchodilator. That's why it's twice daily, in the morning and in the evening. In addition to its effectiveness as regular maintenance treatment in COPD, formoterol should be used in asthma in combination with corticosteroid. Should not be given alone. It is used to control moderate to severe bronchial asthma and control the nocturnal symptom of asthma with corticosteroid. Another new product is butazole inhaler. Is the combination of salbutamol and beclomethasone. Comes in a dose of 100 microgram salbutamol and 50 microgram betamethasone. Used also in most of respiratory disease. It works by dual effect, relaxing the smooth muscle of the airway and reducing the congestion and inflammation of the airways. Pharmacology, approximately 10 to 25% of inhaled dose reach the lung, and the big fraction of the dose is retained in the upper airway and swallowed by the mouth. Butamethasone also reach the systemic circulation. It has hepatic metabolization and excreted primarily by urine. Swallowed portion of the drug is absorbed by GIT, and the half-life is from 2.7 to 5.5 hours. Long-term study have shown that after inhalation of butazole in patients with bronchial asthma, the dose of systemic corticosteroid may be constantly reduced. Butamethasone treatment should be regularly used because of beneficial effect of medication. It will appear only after a few days. So it will reach the maximum dose within several weeks. Indication indicated also to relieve and control of symptom of bronchospasm, treatment of most types of asthma and chronic obstructive airway disease. Here I will give a small note about the use of inhaler. Technique of using the inhaler. First of all, if the inhaler is used for the first time or it's not used for more than 2 weeks, we have to test it by 2 to 3 puffs. Then check the inhaler well before the use 3 to 4 times. Remove the cap, breathe out, and breathe out away from the inhaler, and bring the inhaler to the mouth and start to breathe slowly. In the same time, pressing the top of the inhaler and keep breathing slowly until take full breath. Remove the inhaler from the mouth and hold breathing for about 10 seconds, then breathe away. Buto-asthma syrup. 5 ml of buto-asthma contain 2 milligram. Although the syrup and the tablet and the systemic formulation of bronchodilator is not well used, but still it have some indication in certain cases, especially in pediatric and on patients who are unable to use the inhaler device. The dose for all children more than 12 years, 5 to 10 ml, 3 to 4 times a day. For elderly, dose started from 5 ml, from 3 to 4 times a day. For young children, 2 to 6 hours, 2.5 5 ml 3 to 4 times a day, and the patient from 6 to 12 years, 5 ml 3 to 4 times a day. The pharmacokinetic properties, asthma is absorbed from GIT. That's why it has the side effect of tremor and tachycardia, and have first pass metabolism in the liver, and the peak plasma concentration occur within 1 to 4 hours. And half-life is excreted half of the dose is excreted in the urine, and the bioavailability when taken orally reached up to 50%. Next product is Salbu-Air. Salbu-Air is a nebulized solution of salbutamol, comes in a vial of 2.5 milligram, 2.5 ml. It is a highly selective beta-2 agonist bronchodilator. It facilitate the breathing and make it very easily used in acute severe bronchial asthma and in acute exacerbation of COPD. The usual dose in pediatric, we start with 1.25 milligram, 2.63 milligram from 3 to 4 times a day. In adult, use it from 2.5 to 5 milligram up to 4 times a day. Promiro is ipratropium bromide, also comes in nebulized solution. It's acts on muscarinic receptor. It's muscarinic antagonist receptor. It's considered mechanism of action is to block the muscarinic cholinergic receptor without any specificity of subtype. It results in a decrease in cyclic GMP, and this results in decreased contractility of smooth muscle. The way of use, it's used as nebulizer for children from 0 to 5 years, 125 to 250 microgram, given up to 1 milligram a dose per day. In adult and children more than 12 hours, the dose started from 500 microgram 3 to 4 times a day. Another preparation is compirazole. Compirazole is a combination of ipratropium bromide with salbutamol, comes in a nebulized solution. It's also used in treatment of COPD and bronchial asthma during the exacerbation. It's work as add-on medication. Combined ipratropium bromide with salbutamol, it has synergistic effect as bronchodilator effect. The recommended dose in adult, including elderly and children more than 12 years, single dose given 3 to 4 times a day. Another preparation is budesonide. Budesonide is also nebulized solution, corticosteroid, budesonide, comes in of 1 ml containing 0.25 milligram, and vial of 1 ml contain 0.5 milligram. In children, the dose is 0.25 up to 1 milligram, given daily in divided doses, and for adult from 0.5 up to 2 milligram, given also divided doses per day. The indication indicated in persistent asthma and used in pediatric with in cases of very serious pseudocroup, croup, and in patient with COPD. Thank you.
I think we we missed your question earlier. I have a question, Dr. Husniya, regarding the fixed dose combination inhaler of salbutamol and beclomethasone,
Butazol.
butazol. So, is there any studies or randomized control trials to consolidate using such a combination in patients with either step 1 or step 2 mild asthma?
This medication, Berso, it's the last one. We not it in the Libyan market here, so we don't have too much experience in this drug, Berso, because as you see, doctor, the dose is just only 50 milligram for beclomethasone, small dose, which I think could be beneficial for the patient in step 1 asthma, or for the patient in pediatric. Who need to take a combination of short-acting beta agonist with steroid. But I think in pediatric, many doctors, they use it and they have good background about that.
Right, thank you. So this is the end of the first session. We can probably go back and try to answer any questions and have an overall discussion, then we will take a break. So Dr. Abdullah bin Gibliya mentioned earlier, so how many doses as needed per day, what is the maximum dose? Also patients on regular ICS LABA, on as needed ICS LABA, what dose and what maximum doses? So I'm not sure if Dr. Anam is with us, if he could just shed more light on the question. So I think if I may try to tackle the question. So there is no maximum dose for Meterol, but I think most authors or most experts will say that you shouldn't go beyond 36 micrograms of formoterol. So if you take this, and if you have a formoterol 4.5 containing fixed dose inhaler, then you're looking at no more than 8 puffs or 8 doses per day. So this is to say that this is probably the maximum dose. So if you're using this for step 3 or step 1, either for SOS LABA ICS or step 3 low dose ICS combined with formoterol, I think you're looking at a maximum of 8 doses. Although there is no data, as far as I know, to suggest that formoterol has a toxic range. So I hope this answers the question. Is there any other questions? Otherwise, if there's no other questions, I'll just look at the YouTube broadcasting. There is no questions, so we will take a break. We come back at 1 o'clock, so we have another 20-minute break. So the time now is 12:40. If we take a break for 20 minutes, hopefully we can resume at 1 o'clock with the speaker being Dr. Joseph Elmir, and he will be talking about physiotherapy and pulmonary rehabilitation in patients with chronic respiratory disease. Break for 20 minutes.
أهلاً بك في الفيديو التعليمي القصير الذي سيعرض لك الطريقة الصحيحة لاستخدام جهاز فلوتيفورم HDI الخاص بك. ربما كان طبيبك أو الممرضة أو الصيدلاني بالفعل قد عرض لك كيفية استخدام الجهاز والاعتناء به، ويقدم هذا الفيديو تذكرة لك. لذا فمن المهم أن تحرص على اتباع هذه التعليمات لضمان إعداد دوائك الإعداد الصحيح، وأن يصل إلى رئتيك عند استنشاقه لتحقيق العلاج الفعال لإصابتك بالربو. التعرف على جهاز HDI الجديد. يتكون جهاز فلوتيفورم HDI من مكونات متعددة. يأتي هذا الدواء في عبوة بخاخ توجد داخل غلاف من البلاستيك يسمى مشغلاً، ويحتوي الجهاز على قطعة فموية، ويوجد أيضاً غطاء للقطعة الفموية والذي ينبغي وضعه في حالة عدم استخدامك للجهاز. يوجد أيضاً عداد داخلي للجرعات يشير إلى عدد النفخات المتبقية، ويحتوي الجهاز على 120 نفخة عند الاستخدام، مما يعني وجود علاج كاف في كل جهاز يصلح للاستخدام مدة 30 يوماً. سوف يعد المؤشر عداً تنازلياً كل 10 نفخات بدءاً من 120 إلى 60، ثم يبدأ عداً تنازلياً جديداً كل 5 نفخات إذا تبقى أقل من 60 نفخة. تعني الخلفية الخضراء الموجودة على المؤشر وجود ما بين 120 و 50 نفخة متبقية، وبمجرد تبقي 50 نفخة سوف يبدأ مؤشر الجرعة إلى التحول للون الأصفر، وعندما يبدأ المؤشر في التحول إلى اللون الأحمر فهذا يعني وجود 30 نفخة متبقية أو أقل، وهذا سوف يتطلب استخدام جهاز HDI قريباً. ولا تستمر في استخدام الجهاز عندما تأتي قراءة المؤشر عند الرقم 0 حتى إذا ظهر الجهاز كأحد تفضيلات وصفات الطبيب. ينبغي تخزين الجهاز في درجة الحرارة العادية للغرفة. قبل استخدامك لجهاز HDI للمرة الأولى، سوف يعرض لك هذا الجزء من الفيديو كيفية تجهيز فلوتيفورم HDI الخاص بك وتحضيره للمرة الأولى، أو إذا لم يستخدم الجهاز لمدة 3 أيام أو أكثر. لتحضير الجهاز، يرجى إزالة غطاء القطعة الفموية، ثم رج الجهاز جيداً. يرجى إزالة القطعة الفموية بعيداً عنك، ثم الضغط على علبة البخاخ لإطلاق نفخة واحدة، والذي يعرف أيضاً باسم تشغيل الدواء. كرر خطوة التحضير 4 مرات في المجمل، وتذكر أنه ينبغي الحرص دائماً على رج جهازك قبل كل نفخة فوراً، وهذا لضمان مزج الدواء بصورة ملائمة، وأن الدواء قد أصبح جاهزاً للاستنشاق. بعد تحضيرك جهازك، أصبح الآن جاهزاً للاستخدام. إذا تعرض جهازك إلى درجة حرارة التجميد فيجب تحضيره أيضاً قبل استخدامه مجدداً، وفي هذه الحالة يجب ترك الجهاز ليدفأ في درجة حرارة الغرفة لمدة 30 دقيقة، ثم يجب تحضيره كما هو مبين أعلاه لضمان عمل الجهاز على نحو مناسب. كيفية استخدام جهاز فلوتيفورم HDI. سوف يعرض لك هذا الجزء من الفيديو كيفية استخدام جهاز فلوتيفورم HDI على نحو مناسب لضمان تلقيك الجرعة الصحيحة للدواء. أولاً، يرجى إزالة غطاء القطعة الفموية، ثم تأكد من نظافة القطعة الفموية للجهاز وخلوها من الأتربة. وينبغي رج الجهاز قبل كل نفخة فوراً. ولاستخدام الجهاز ينبغي وضعه في وضع مستقيم أو الوقوف. أخرج زفيرك بقدر ما يناسبك. أمسك الجهاز في وضع مستقيم باستخدام إصبع الإبهام على قاعدة القطعة الفموية وإصبع السبابة أو بأعلى علبة البخاخ. ضع القطعة الفموية على فمك ما بين أسنانك وضع شفتيك حولها. ولا تعض القطعة الفموية. تنفس ببطء وبعمق عن طريق فمك، وبعد البدء في التنفس اضغط على علبة البخاخ لإخراج النفخة الأولى، واستمر في التنفس بثبات وبعمق، ثم احبس نفسك بقدر ما يناسب.
دكتور جوزيف, if you could unmute yourself, ما نسمعوش فيك.
Hi, did you hear me?
Yes, we can hear you.
Okay. 2 minutes and I will start. Are you seeing the presentation?
Yes. Yeah, so you're on
Okay.
full screen. You're on full screen and we can hear you nice and loud.
Okay. Hi, I'm Joseph Elmir from Lebanon. I'm a doctor of physiotherapy. I hold a master in research in physiotherapy. I'm the head of respiratory care unit at CISOBEL. It's an NGO organization in Lebanon for children with disabilities. I'm lecturer at St. Joseph University of Beirut. First of all, I'm glad to be with you today, and I would like to thank the organizers and especially Dr. Ahmed Al-Yousafi. Let me start my presentation. My title of the presentation is Pulmonary Rehabilitation and Physiotherapy in Patients with Chronic Respiratory Disease. As you see, it's large title, but I will try to summarize a little bit all the disease. So I don't have any disclosures. I don't have any conflict of interest with this presentation. As you know more than me, that spiral of respiratory disability, it's breathlessness. It will lead to inactivities, to deconditioning, reduce exercise capacity, and at the end, it will lead to disability or mortality. So this quality of life, it's not very easy to manage. We will try to find a solution with these patients. So what's the consequences of chronic respiratory disease? We have dysfunction of peripheral muscles, dysfunction of respiratory muscles, inspiratory muscles or expiratory muscles. We have abnormalities on nutritionals. We have cardiac impairment, skeletal disease, sensory defects, and psychosocial dysfunction. These patients have too many problems. That's why pulmonary rehabilitation is here. What's pulmonary rehabilitation? It's the definition by ERS or ATS or SPLF, the French association. It's an evidence-based intervention for patients with chronic disease, and it must be multidisciplinary. We will see who will work with these patients for months and months. So what shall we do? It will reduce symptoms. It will optimize the physical and psychosocial conditions, reduce healthcare costs. Benefits of rehabilitation, as you know, it will improve exercise capacity. It will reduce the dyspnea. It will improve the quality of life. It will reduce the hospitalization and the length of stay in hospital. It will reduce the depression and stress and anxiety. It will improve upper limb function, and at all benefit will beyond immediate after the period of training. That's one of articles appear in 2015. We can see like dyspnea. Okay, after 6 months of we can see it will the improvement of the dyspnea. Okay, and the cough, it will improve also, and the exercise tolerance also, sputum expectoration, the patient will expectorate less and less after this rehabilitation. As I said, it's a multidisciplinary work. Have a doctor of pulmonary, we must have a social worker, we must have a doctor of gastroenterology and enterologist. We must have nurses, physiotherapists, nutritionists, cardiologists, and a psychologist. So this is the team who will work with to do or to make this pulmonary rehabilitation easy and well followed by the patients. Today, I will tackle the physio rehabilitation, what he will do, and how he will do it. Therapist must prevent, explain, and treat the situation for the patient. He must rehabilitate the patient, advise the patient and the family, educate the family and the patient. Why the family? Because we have too many children who have cystic fibrosis or bronchiectasis or neuromuscular disease. We can educate the family to do it also at home. So we don't treat every patient. We don't have a protocol ABC for cystic fibrosis. We must do that. Or for COPD, we must do BBB. So we have in physiotherapy, also like in medicine, we must assess the patient. Okay, our assessment, it's different than the doctor's medical doctor's assessment. We have the paramedical assessment. I mean the spirometry, blood gases, SpO2, oximetry, capnometry. We can do it at home or at the clinic. We must, after these two big assessments, we will put our diagnosis, our own diagnosis, our physiotherapy diagnosis. For example, he has an obstructive disease with fatigability on MMRC. 6-minute walk test is too short. It's an example. After these three assessments, we will put our strategy of treatment. So in physiotherapy, what we can do exercises, respiratory exercises or motor exercises, airway clearance, NIV, non-invasive ventilation, and we can learn the patient and the family how to do with their disease, what to do with their disease. For respiratory exercises, we learn the patient how to do relaxation exercises, how to breathe with pursed lip breathing. For example, he breathes in with his nose and he will breathe out with her lips, but pursed lips, not open lips, open mouth. Okay, for example, we learn them to do diaphragm breathing, because most of them have shallow breathing or an inadequate breathing. So we ask them to, when they breathe, they must put their belly up, then her thorax up. Then when we'll exhale, they must put her belly down and the thorax down. Okay, so this exercises will improve the coordination and the function capacity of the patient. Dyspnea will go down, anxiety will go down, and depression will go down. So for physical exercises, we can avoid muscle, these exercises will avoid muscle wasting. We can learn them how to use bicycle, walking, treadmill, stair climbing, sit and stand, arm cycle ergometer, have lifting with weights. Okay, too many exercises for them. We can learn them how to stretch their muscles to release the muscle of the shoulder and upper thorax. We will learn them how to make exercise with stretching to prevent joint stiffness. So too many exercises must be learned to this patient to do it at home or in clinic. So these exercises must be minimum at least 3 days per week. It will be preferably if we can do it 5 or more times per week of this exercise. So here we have an article appeared in 2016. We can see how with electrostimulation, electrostimulation is a small device that will put it on 2 points of muscle and will give him stimulation. And like this, the muscle will contract alone. So we can see after 6 months of this treatment, we have more. The function of exercise is more in population who has this neuromuscular stimulation, and also in quadriceps, because quadriceps, it's the big muscle we use it to assess the COPD functionality. So we can see that with this electrostimulation, how we can have more voluntary contraction of this quadriceps. So airway clearance. The airway clearance is, you know it very well. Every doctor, medicine doctor, asks the airway clearance at the first for pulmonary disease. So what the aim is to clear sputum from the airway in order to optimize respiratory and status and slow the disease progression. So we have too many techniques. We have the active cycle breathing technique, ACBT. We have autogenic drainage technique. We have forced expiratory technique. We have postural drainage and percussion. These days, we have too many articles explaining that they are a low efficiency of these two techniques. So for airway clearance technique, we have manual technique and we have instrumental technique. For manual technique, we have the positioning. The positioning, I will tell you today something new about every doctor, and the old school of airway clearance technique was, if the patient have secretions in the upper lung, we'll put this lung in the air and the other lung at the bed, and like this, the secretions go from up to down. That was the old school. Now we have another school. We have too many studies to prove it. We put, for example, here the lung where there is sputum down, and the lung without sputum up, and we ask the patient to inhale and make an expiration with glottis open in lateral posture. We ask him to make okay. For example, here you can see the work of diaphragm. It's more efficiency here at the lung of down near the bed, okay, and we have the hand of the therapist will push up like this, and this one will push down. So this technique, we have too many studies now proving his efficiency. So we have huff and cough technique. We ask the patient to inhale with his nose, and when will exhale, to huff, like for example, like he blow a ping pong ball from his mouth. We will ask him to do like this. Okay, and he must do it 2-3 times, and like this we can have secretions. He can expectorate the secretions. We have another operation to inhale deep for 3-4 times, and then to exhale, then to inhale for 3-6 times, and to exhale, and after 2-3 times of breathing deeply and breathing control, we ask him to huff and cough. Okay, that's why he can expectorate his secretions. All this exercise, if the patient is conscient and can do it. So we have autogenic drainage. Here we can ask the patient to inhale slowly for 2-3 times, and the second 2 times we ask him to inhale more volume, and then to inhale more volume. At the end, we will ask him to exhale with coughing machine. So you can see we can inhale 2-3 times, then we inhale more, exhale. At the second stage, we inhale another time, but with volume bigger than the first time. And the stage 3, we have the volume bigger and bigger, and at the end we ask him to huff and cough. Postural drainage, we can use it only. We use it with people who have bronchiectasis or too much secretions, like if they have cystic fibrosis with big quantity of secretions, we can use it, because there are too many studies now that telling us that this technique have no efficiency and have too many contraindication. So from manual technique, we will go to mechanical technique. I don't know if this instrument can we found it in Libya or not. It's OPEP and PEP technique and a cappella. They will have here this flutter have a ball. Let me see. Okay, we have this ball here, and when the patient will blow through this device, he will create an oscillation to this oscillation will oscillate the lungs intrapulmonary oscillation. So that's why we can move the secretions from the lungs to and get the patient expectorated. This is another type of instrument. It's a cappella. We can use it, and also she will make oscillatory positive expiratory pressure. We have this oscillation intrapulmonary. We will I think somebody will ask himself why we need oscillatory intrapulmonary. We can do it from extrapulmonary with machines or with hands. I don't know if any of the physiotherapists can make 13 to 20 hertz per second oscillation to move the secretions. Why 13 to 20? Because we know that the movement of cilia must be between 13 and 20 to be efficient. So I don't know if we can do it with our hands Or if we can do it, can we do it in the thorax? And are we sure that this vibration of 13 to 20 will arrive to cilia to move the secretion? Or with this one, we can do it and we can arrange the oscillation. Here, the other type of instrument, the TheraPep. Here, the patient will blow with this tube, and it will create a positive expiratory pressure at the lung, and will open the lungs. It will help them to expectorate. These are device with mask is TheraPep. Many dimension of 20 dimension that the patient will blow on this mask. If we want the flow be, if will wear this vest, and this machine will give him a vibration for all the lung from up to down. And here we have too many sizes of this vest, and we will help him to move the secretion and collect it, and he will crush it. He will expectorate it out of his lungs.
Sorry, Dr. Amir, are you able to finish in about 5 minutes?
Yeah. Here we have the new device. It's Simeox. It's this device will help the patient to expectorate. The only thing, the patient will inhale and will put this tube in his mouth, and the machine will suck the secretion from his mouth with some movement of oscillation. Here we have a video. I don't know if it will work. Look, without Simeox, you can see this expectoration in the tube. Okay, I don't know if you can see it. It doesn't move. For example, here it's the same expectoration in the same tube. Sorry. You can see how this expectoration it moved from down to up. So non-invasive ventilation, we can learn the patient how to use it, how to put his mask, how to use his NIV. We can inform them. We can tell him which positioning must take. We can help him to expectorate. We can put his interface, his mask, and see if it's adapted or not. We can help the doctor with parameter of the NIV, and we can learn the patient about his circuit, and if it's around, how to do. This NIV plus oxygen in obstructive patient, it improves the quality of life. It will improve the oximetry, nocturnal oximetry. He will dyspnea will go down, and he will improve the endurance. Patient education and the education we explain to the patient all about
Dr. Joseph, I think there's I think you have a problem with your connection. We're not, yeah, you're interrupting, I'm afraid.
and either the doctors
So Joseph, are you able to
cannot
reshare your screen?
do.
Share your screen again.
I'm sharing it. You can see it now.
Okay, so we can see your screen again.
Do you see it now? You can see it.
Yes, we can see the screen and we can hear you nicely.
The multidisciplinary team, we can do everything as one team. We cannot do it alone. And if you want to work hard, work it in silence, and let success make the noise. Thank you very much.
Thank you so much, Dr. Joseph, for such a intriguing presentation. As you know, most of the spectators here are doctors, respiratory doctors. So I have two questions, if you don't mind.
Okay.
The first question is, for a Libyan chest doctor working in a Libyan environment, what would be your tips for a Libyan doctor to work on a bronchiectatic patient with lots of sputum problems in the absence of any previous physiotherapy training and also in the absence of a chest physiotherapist in the city, for example? So this is the so if you could just share with us one or two or three tricks, being the bare minimum. The next question is, whilst working with COVID patients, I see a lot of nurses and physiotherapists banging on patients' chests, saying that this is beneficial. Now, we know that interstitial pneumonitis is usually non-productive and there's little or no secretions, especially if the patient is not on the tube. So I don't know if you could share with us any insights or views with regards to chest physiotherapy in a COVID-19 patient who is severely sick, but not yet on the tube, so not intubated.
Okay. Okay. For the first question about how can we help physician doctors to help their patients. We can do doctors can give the patient too many tips. For example, to blow a facial tissue, for example, to blow. I don't know in English. I know it in French. To blow الشمعة. You know شمعة?
Yes. Yeah. Shama, candle.
Candle. Okay. To blow the candle as long as he can. Okay. To do exercise, to walk, to run. That will help him to expectorate. Never learn the parents to do clapping, because clapping, it's not recommended now. He must, for example, if he has a pie, you know what's pie? شاليمو المصاصة هيدي الطويلة.
Yes. Yeah.
Okay, he can blow in a cup of water, or he can use كان في لعبة هو نحن بنشيلها وبننفخ فيها صابونة. اوكي، يعمل بالونات.
A bubble maker, I think.
Yes, the bubble maker. Okay, sorry, I'm French educated. That's why I don't have the words in English. Okay, we can use this.
ثقافتك فرنسية.
نعم. So we can use too many games that will help this bronchiectasis patients. Okay, for example, if we can make a boat from paper and blow this paper boat on a big jar of water. All these are games that patient can do it.
So these are very similar techniques to huffing and puffing techniques. This is
yes.
Yes, but I also now understand that التخبيط على الصدر is not recommended anymore.
التخبيط على الصدر, it's not recommended. There is too many articles, even in England or in US, they said it's not beneficial. But we will see from here to 20 years, nurses and physiotherapists are making these clapping techniques. Even عند اللي عندهم كوفيد، نحن بنعرف انه اللي عندهم كوفيد هن ما في عندهم hypersecretions. اللي عندهم كوفيد
نعم exactly.
interstitial disease، ما عندهم secretions الا اذا كان عندهم disease تاني مثل COPD، مثل cystic fibrosis، مثل asthma، معقول يعملوا secretions، بس هن بالاصل ما عندهم. بس لانه سوري اذا عم بحكي بالعربي، لانه الناس عندنا براسه انه فيزيوثيرابيست يعني القرع على الصدر، يعني الطبطبه، يعني نعلي له اجريه لفوق بينزلوا السكريشنز من تمه. هدول اتس very old techniques، لازم نغيرهم.
طيب جميل جدا. So the advice and the evidence is very clear. Now is the time to try and implement the advice and the evidence. So good luck with that. سواء كان في لبنان ولا ليبيا or elsewhere.
مضبوط، في كل العالم العربي. وانا تركت لكم الميل تبعي ورقم التليفون، انا مستعد تساعد قد ما بدكم.
تسلم شكرا جزيلا دكتور جوزيف. Thank you very much for such an extensive informative talk. I will just take a few seconds to look to see if there's any questions.
Okay.
No, I don't have any questions.
Okay.
Even nothing from the small audience behind. I can see Dr. Ahmed El-Bouseifi is waving at you, so I'm not sure if he has any questions. So with that, we will move on to our next speaker, Professor Tudor Popov. and he will be speaking to us about biological agents in severe asthma.
Thank you.
Dr. Popov has been here with us throughout the morning. He's been very patient with us. So we're very grateful, and we look forward to your presentation. Are you able to share the screen?
Thank you for the introduction. Assalamu alaikum. Let me share my screen first. For some reason, can you see my slide?
Not yet. We can see your beautiful face.
Let me see why can't I'm trying to push the share button.
Dr. Popov, you have to select the box and then you can press share. So you have to select the
Okay,
the box.
I did it. Okay. Can you see my first slide here, my title slide?
Yes, very nice.
Okay then. Okay, dear colleagues, I'm Dr. Ted Popov, and I'm a professor at the University Hospital Sveti Ivan Rilski in Sofia, Bulgaria. I have no conflict of interests to share and to disclose. I'm very glad to be here with you today, and that's because of the nice invitation I got from Dr. Ahmed El-Bousifi. And now I'll proceed without further ado to my first slides here, because I hope I'm given 25 minutes. Is that right?
Yes, absolutely.
Yes. So I'll be telling you about what I know and what I have been experiencing in my long time studies in severe asthma. Mostly I'll be sharing some slides with from GINA, which is the authority on asthma in general, the Global Initiative for Asthma. And here I'm grateful to Dr. Anam El-Arabi for presenting the GINA classifications. But I'll start first with the importance of the question that I'm presenting to you, and this is the serious consequences of severe asthma. We know that there are about 300 million of asthmatics around the world. And unfortunately, there are some 15,000 patients who die each year from the asthma attacks in Europe. The costs are enormous, but those who die usually are the severe patients. Actually, we have to make some differentiations here and some definitions. What is severe? What is difficult to treat? And I'll present this on this slide, again from GINA. It tells us about the proportion of adults who have difficult to treat or severe asthma. So out of the big spectrum of patients with different asthma severities, we have some 24% which have GINA step 4, step 5 treatment prescribed. These should be patients who need all the medicines that we can apply so that they can lead a normal life. Out of these 24 patients, 17% still have their symptoms uncontrolled. But there are different reasons for that. Some of them do not comply with the treatment, don't adhere to the treatment. Some of them have poor technique of inhalation of their drugs. So when we take only those patients with poor control of asthma, it's about 4%, 3.7%, who are doing everything the way they should be doing it, but still have poor control of their asthma. And these are the true severe asthmatics. So let's go to the definition of severe asthma. Asthma that requires treatment with guidelines suggested medications for GINA steps 4 to 5. These are high-dose inhaled corticosteroids, long-acting beta agonists and leukotriene modifiers, or theophylline. And for the previous year, they had the need of systemic corticosteroids for at least 50% of the time. These are called uncontrolled. And if they remain uncontrolled, provided they're taught the proper way of using their inhalers, and if they comply with the medication that has been prescribed, these are now the serious asthmatics. So the definition of severe asthma is based on poor symptom control, frequent severe exacerbations, which require bursts of severe systemic corticosteroids, serious exacerbations, hospitalizations, ICU stay, and also mechanical ventilation, airflow limitation after appropriate bronchodilator with help for FEV1, controlled asthma that worsens on tapering of these high doses of inhaled corticosteroids or systemic corticosteroids. So we have two schemes that have been already presented as part of the asthma management structure. We have the stepwise approach for initiation of asthma treatment, and we have the different steps that where we begin with prescribing and teaching our patients how to treat themselves. And we have also this stepwise control-based approach for asthma management, where we need to assess the result from the previous period of treatment, to adjust the proper treatment, and then we have to again come back to the patient and review the response. Dr. Anam has been talking about the step 2 and step 3 treatment, and step 1, of course, where we discuss also the short-acting beta agonists who are now high in stage. I'll be talking about the step 4 and step 5 treatments, where we need something additionally in the severe asthma cases in order to improve and to keep a good asthma control. So how can we do that? We need to address modifiable risk factors contributing towards poor asthma control. We need to optimize the inhaled corticosteroid long-acting beta agonist dose. We need add-on treatments, and this could be done without phenotyping. If we could base our prescription of new treatment and add-ons on sputum measurements, that will be all right, but this is somewhat difficult and requires some very specialized laboratories. There are other ways which could tell us about the phenotype-guided add-on treatment, and this is actually what I'll be talking about. There's also this bronchial thermoplasty, which is a very limited method because of its price and because of its nature. the nature of this procedure is quite invasive. And to be honest, I don't think it's a solution to the problem, and it poses some risks when you do it. So when we want to select a biologic agent for the treatment of our patients, now we have a spectrum of asthma, some of which would be allergic, some of which will be non-allergic. So far, we have biological agents which are approved for allergic asthma and for eosinophilic asthma. What are the basic differences? When you have allergen trigger for the asthmatic symptoms, this would be called allergic asthma, and it is driven by adaptive immune system mechanisms, and it produces IgE antibodies, interleukins 4, 5, and 13, and they act upon the smooth muscle cells, as opposed to the allergic triggers, where the innate immune system triggers uncontrolled growth of and production of eosinophils with their mediators IL-5 and IL-13. So we have now approved biologics that would be basically for those two asthma phenotypes. And we also have biomarkers for the type 2 inflammation. And these are the eosinophil numbers, both in sputum and in blood. You have the IgE in blood, the total IgE. We need also to have some information about the specific IgE to external outdoor allergens or indoor allergens. And another biomarker would be fractionally held breath nitric oxide. So these are now the possible avenues that we can follow. We should consider add-on biologic for patients with severe asthma who have eosinophilic or allergic biomarkers and who would eventually or need maintenance treatment with oral corticosteroids. So oral corticosteroids and systemic corticosteroids are basically the problem that we need to somehow circumvent. So which biologic in those patients? We can start with anti-IgE, provided we have this undoubted influence of allergic triggers. It requires specific IgE sensitization. We need to measure total IgE and weight within of the patient in order to install the proper dosage. And we need to have some past data for exacerbations. Alternatively, if we have eosinophilic markers, if we have eosinophils, then we can go for the anti-IL-5 and anti-IL-5 receptor treatment. And there we need also to have the severe characteristics of the patients with exacerbations during the last year, and blood eosinophils need to be more than 300 per microliter. We can go for the anti-IL-5 receptor, where we can also have to consider exacerbations in the past, where if we measure FeNO, which would be above 25 particles per billion, and blood eosinophils could be somewhat lower, 115. And these are the preparations that we have at our disposal. This is the first ever biological agent, the omalizumab, the anti-IgE, which connects to the immunoglobulin E antibodies in the serum, in the blood, and in the mucosa, and blocks them from combining with the specific targets they have on mast cells. We have the two different agents, reslizumab and mepolizumab, who are directly coupling to the interleukin-5 antibodies. And you have also benralizumab, which is binding the interleukin-5 receptor alpha on the eosinophils. We have also the targeting IL-4, IL-13 antibody, dupilumab, which combines with either IL-4, mostly with IL-4 receptor on the cell surface. It's important to state that because allergy is a systemic disease, the different biological treatments have benefit not only for the asthma of the patient, but they have some benefits for the comorbidities of the patients. And we need to think of it when we prescribe and when we choose our biologic. For instance, anti-IgE, omalizumab, can be useful in food and drug allergies for during desensitization. It is a unique agent also in chronic urticaria. It has shown promise in bronchopulmonary aspergillosis, and it can be used also in chronic rhinosinusitis with nasal polyps. As for the anti-IL-5 and IL-5 receptor alpha, these are reslizumab, mepolizumab, and benralizumab. We have their effect also on hypoeosinophilia, on chronic rhinosinusitis with nasal polyps, still to be shown properly, and in the Church-Strauss syndrome. As for the anti-IL-4, IL-13, we have some good promise in atopic dermatitis and also in chronic rhinosinusitis with nasal polyps. Why should I be so insistent about the effect on chronic rhinosinusitis with nasal polyps? Because most of the cases of patients with chronic rhinosinusitis with nasal polyps have also severe asthma, and maybe some of them aspirin hypersensitivity, intolerance. In those cases, we need to alleviate the suffering of both the asthma and the chronic rhinosinusitis. And some patients actually are suffering most from the chronic rhinosinusitis rather than from the asthmatic symptoms. And we have some here studies shown about the Sinus 24 studies and the Polyp 1, Polyp 2 studies, where dupilumab was compared to placebo and where it was very well documented that the treatment with dupilumab greatly reduces the symptoms of chronic rhinosinusitis. This goes true also for the Polyp 1 and Polyp 2 studies. There are studies that have been carried out with omalizumab as well. So we have this paradigm that we are following nowadays. This is the allergic eosinophilic asthma that I spoke about. This is the non-allergic eosinophilic asthma and the non-eosinophilic asthma. And the last one, the non-eosinophilic asthma, is lagging behind the other two phenotypes because of the lack of approved biologics. This doesn't mean that they are not in the pipeline, those new agents that are coming, but basically we're waiting for some new agents to come into our armamentarium. Let me just go through the comparative table of omalizumab versus mepolizumab, praslizumab, benralizumab, and dupilumab. These are the asthma exacerbations that they can reduce eventually, and they can go from 25% reduction to 70% reduction in the case of dupilumab. The lung function basically is improved, and we have a special focus on the corticosteroid weaning. And in most patients, we can reduce the treatment with systemic corticosteroids, and we can also even get rid of those corticosteroids. In most cases, though, we can reach 50% weaning from the chronic oral corticosteroids in the true severe cases. We are talking about those five different agents which are approved nowadays and which are being used in all countries, basically. But still, there are news that would be coming, and this is a look at the future. All those boxes that are marked in red are with drugs that have been already approved as antagonists of the molecules that are here. And you can see the IL-4, IL-5, IL-13, IL-4, 5-13, IL-4, IgE, IgL, IL-5-13. So these are the drugs that I have been talking about. But we have also some investigative drug targets. And perhaps the most promising one would be the thymic stromal lymphopoietin and the interleukin 33 and 25. And we have studies going on in that respect. There's another possible antagonist here, the so-called CRTH2. This is the chemoattractive receptor analogous molecule expressed on Th2 cells, which is basically an antagonist of the prostaglandin D1 receptor. So I'll just tell you about it, because the TCLP is at the very beginning of the waterfall of the cascade of events happening in different phenotypes of asthma. We need to look at this molecule and of those drugs now that are under development because of the possible benefits we can have. And we need to differentiate between two possible targets that we could have, two possible follow-up events that will happen. We could actually want to reach a complete remission of the asthma, and this could stay on after we take off the treatment with the biologic that we could have. So what is the difference? The clinical remission on treatment. This means that for over 12 months, we need to have sustained absence of significant asthma symptoms based on validated biomarkers, optimization and stabilization of the lung function, patient healthcare agreement regarding disease remission, and the use of systemic corticosteroids for exacerbations should be well reduced. And if we have this carry on off treatment with the agent in question, then we have a remission. And if the complete remission lasts for over 12 months, this is something that we want. This is basically the cure of difficult to treat asthma. So the potential for complete remission has been targeted by the anti-TCLP agent. This is the pathway study. Unfortunately, it doesn't show, but it's the agent tepezolizumab, which is being shown here. And it, as you can see, it can produce some amazing effects at the time that it is introduced into the organism. This is the changes in sputum eosinophils, and these are the different mean changes in the fractionally held nitric oxide. These are different doses. And there's another new development on the horizon, and this is the inhalation treatment with the biological agent. This could be achieved with the anti-TCLP FAB fragment. And this could be a major breakthrough because it would save the patient the intramuscular subcutaneous or intravenous parenteral application of the other biologics that we know now. So the key points, the take-home message here that I want to make is that difficult to treat asthma is not the same as severe asthma. Just remember the number of severe asthmatics that are truly severe, like 4% of all the asthmatics. Biologics are available to treat severe asthma. Patients must already be receiving optimal inhaled therapy with, as indicated in the GINA document. Biologics could be preferred over oral corticosteroids, and there's no question about that. I shouldn't be persuading you that this is the case. Treatment should be evaluated every 4 to 6 months in order to make sure that the patient is going the right way. And basically, this is my presentation. There could be many more things to be mentioned, but because of constraints of time, I would stop here. And here you have my email address. I could discuss with people anything that might be of interest. Shukran.
شكرا دكتور. Yes, so thank you very much for next presentation. I think Dr. Husniya wants to add a question.
Hello, Doctor, do you get that
Hello.
question?
Yes, yes, of course. Please go ahead.
Okay, my question, according to the new modification of GINA guideline in step 1, adding ICS with the formatrol, do you think this new modification will have impact on severe asthma? By another word, I mean it will affect the severity of asthma, and we will forget about the term of difficult asthma or severe asthma.
Interesting question. I wish it was the case. Unfortunately, again, we know that many patients, there's something's happening on the screen here. I don't know what. Maybe I have to. So what you're asking.
So you can unshare your screen, Dr. Popov.
I have to turn off my screen, my camera. Okay, I turned off my camera. No, it doesn't work. Anyway. That is happening. I hope it doesn't explode. So, to come back to your question, the logic would be that if we treat early enough in the first step with the inhaled corticosteroid as needed, the progress of the severity may not go to steps 4 and 5. Is this your reasoning? If this is your reasoning, I believe that it could be an ideal case if this happens, but I doubted that many patients would be saved from progression of their severity of asthma just by taking initial inhaled corticosteroid early enough. I believe that there are genetic and environmental factors that wouldn't let this happen. We do have our portion of severe asthmatics, and we have to deal with it independent of the early phases of the severity management.
Right, okay. So I have a question from Dr. Isan, my colleague here. You mentioned in one of your slides something about the anti-IgE having been tested on patients with bronchopulmonary aspergillosis. So I wonder if you have any more information on this. And also, his second question was, so the indications for biologics in patients with asthma is that they are on step 4-5 treatment, and especially those patients on long-term oral steroids. The question is, how long do they have to be on oral steroids for them to be considered for biologics?
Okay, the first question. Bronchopulmonary aspergillosis is a tricky disease. It starts as allergic asthma, and at one point it detaches from the allergic origin of the asthma, and it begins a self-sustained chronic inflammation. At the beginning, when you have the allergic component, you can use the omalizumab, and it works pretty well. There's a study on that, but I can't really tell it by heart now. Anyway, I can look for it, and eventually, if I know the email address, I would send it to Dr. Assis. The second question was about the progression to step 4 and step 5, right? Could you repeat the second question, please?
Yes, absolutely, Dr. Popov. So so the question is, how long do you have to be on oral steroids for step 4 or 5 for you to be then considered for biologics?
You know, we are all waiting for patients to become chronic and to be taking loads of oral steroids and systemic steroids before we consider them for biological treatment. Actually, the perspective is changing now. GINA are recommending that the biological treatment would be indicated and should be preferred before the oral and systemic corticosteroids would be started. Because once you have the remodeling of the airways, it's going to be much more difficult for the biological agents to exert their effects. So what I'm saying is that you should start the biological treatment as early as possible when you actually see that there's no good control on the maximal doses of standard inhaled corticosteroids and other add-on treatments. So again, try to do it as soon as possible, but I know that it's not easy because of the price of the costs involved and because of the fact that you should somehow persuade the insurer and the healthcare system that the patient is suitable for this treatment.
Thank you. Yes. So as soon as possible, or as soon as you finish your assessment, then you could proceed to biologic.
Or you have
one final question, I think. The next speaker is. Sorry?
And if you have the money in your pocket and you don't depend on the healthcare system. Okay, I'm saying that actually
yes,
are acting also in earlier phases of the asthma severity, but nobody's paying for that.
Yes, absolutely. So just one final question before the next speaker, because he's eagerly waiting to start. We know from historically with omalizumab is that you have to be extremely careful about administering the first dose because of events of anaphylaxis and anaphylactic shock and reactions and things like that. So in your personal experience, the more later biologics, mepolizumab and Benra and Resla, how careful do you have to be in terms of administering the first doses? Can you do them as an outpatient? Do you have to admit them? And also, if you could shed more light on your experience in terms of side effects and complications.
I have hundreds of patients with omalizumab and dozens of patients with mepolizumab, benralizumab. I haven't seen a single serious adverse reaction to omalizumab, and there have been just local reactions to omalizumab or to mepolizumab or to benralizumab. I think that one has to be careful, of course. One has to question the patients about previous anaphylactic or anaphylactoid reactions. And this saves the pain of preventing them with some antihistamines before that. It could be, of course, outpatient management, but still the patients, for the first shots, they have to come to the clinic just to make sure that everything's the way it should be. And then many of those treatments are tailored for home usage. So now the GINA committee carefully contemplates the developments and is about eventually to, and is prompting us that home management is a possibility, a distinct possibility.
Okay, thank you very much. That's a beautiful answer, especially coming from somebody who's probably working in a very rich part of the world where you have hundreds of patients on such expensive agents. Thank you very much again, Dr. Popov. We hope to invite you and host you again in another event. We now move on to Dr. Mohammed Sanusi, and he will be speaking to us about COPD and the Global Initiative for COPD, GOLD.
Assalamu alaikum. Hello, everybody. My name is Dr. Mohammed Sanusi. I studied medical school in Sirte, Libya. Then I went to Canada to do my post-graduation study in internal medicine and respiratory medicine. I did the Canadian Board of Internal Medicine and the fellowship in respiratory medicine. I'm going to be talking today about the GOLD of 2020, or the Global Initiative of the Global Initiative of 2020. Basically, the GOLD has already made slides for teaching purpose. We're going to be based our presentation on these slides. Obviously, GOLD has made the recommendation based on evidence-based medicine. And as you see the table here, evidence A, B, C, D, and most of you, I'm sure they're aware of this based medicine initiative. The etiology of COPD is known to most of us. The main cause, smoking or pollution, either indoor or outdoor pollution, plus the host factor, including genes, childhood infection, and other factors. Pathobiology, including impairment lung growth, accelerated lung injury, lung and systemic inflammation, and then the pathology based on small airway destruction and abnormality, emphysema, and systemic effect, which all of these lead to the airflow limitation and the clinical manifestation. Airflow usually persistent, airflow limitation in COPD, opposite to asthma, which is usually not persistent. The mechanism of underlying airflow limitation in COPD, two way, usually small airway disease or bronchial disease. The small airway include airway inflammation, fibrosis, luminal plug, increased airway resistance, or loss of alveolar attachment, and decreased elastic alveoli. This slide, I find it very full with information, actually, very informative, where you see the normal lung, you see the bronchiole, how it looks nice, and in the other side, in COPD, how it's destroyed, fibrous formation, loss of alveolar attachment, and this is very important, the alveolar wall loss in COPD. When you lose the wall of the alveoli, that lead to the destruction of the alveoli and emphysema. So this is a comparison between asthma death and severe COPD. As you see, the inflammation is very, very similar, or on both sides there is inflammation. But when you look at the fibrosis, you can see it's more in COPD and mild in asthma. Alveolar destruction, it's not seen in asthma, but it's very common in COPD. This is an air trapping in COPD. As you see, the normal airway, and as you see, the alveolar attachment looks very nice. When you look at the COPD and inflammation, you see how the airway got thickened airway with loss of alveolar attachment and loss of elasticity. And this is a very important factor in pathophysiology and pathology of COPD. That's during expiration. If you look at the expiration, the airway closed in COPD, and because you see the alveolar attachment being lost and destroyed. This is a diagram showing the FEV1 in normal patient. TR1 is the normal, as you see. TR2, patient with small lung with no COPD. TR3, clearly patient with normal initiative FEV1 with rapid decline in FEV1 leading to COPD. TR4 was you see small. The best way to diagnose COPD, either you have the risk factors, which we spoke about, host factor, tobacco, occupation, indoor, outdoor pollution, symptoms including breathlessness, chronic cough, sputum production, and to confirm a diagnosis, you have to do a spirometry to get the diagnosis. These are key indicators to consider diagnosis of COPD in a patient who's older than 40, who have any of these. You should think about COPD dyspnea that is progressive over time or characteristic with worsening during exercise or persistent. Also cough, chronic sputum production, recurrent lower respiratory tract infection, history of risk factors, as we mentioned them already, host factor and other factors, family history of COPD, and childhood factor. These are other causes of chronic cough you should think about when you have a patient with a chronic cough, including asthma, lung cancer, TB, bronchiectasis, left side heart failure, interstitial lung disease, cystic fibrosis, idiopathic cough. And extrathoracic causes of cough include chronic allergic rhinitis, posterior nasal drip, upper airway cough syndrome, reflux, medication like ACE inhibitor. This is the shape of FEV1 in the normal individual and a patient with obstructive disease. As you see, in the normal, patient was able to take a full inspiration and expiration with forced vital capacity around 5 liters, sorry, with an FEV1 of 4 liters with a normal ratio. Instead, when the patient have obstructive airway disease, you can to, or what should we consider when we perform spirometry? These are like rules for anyone who performs spirometry. Things should look at or consider during doing a spirometry: calibration, hard copies, describing how FEV1 and FVC should be measured, talking about post bronchodilator, the dose, and the time, how long patient should wait after or before doing the spirometry after receiving bronchodilators, and it goes on in details about guidelines how to manage or how to do the spirometry. Here, classification of airflow limitation and severity in COPD, goal 1 called and goal 2, goal 3, goal 4. Goal 1, we have a mild obstruction with FEV1 more than 80. Obviously, FVC ratio has to be less than %. With a mild, FEV1 will be more than 80. Moderate FEV1 more than 80 but less than 50%. Severe FEV1 more than 50 with FEV1 less than 30, and very severe FEV1 will be less than 30. Then we have a modified MRC dyspnea scale with the CAT assessment. The both of them used to assess the symptoms and the breathlessness in patients with COPD, because later on we're going to need them when we are using ABC. We're going to use them when we need the ABCD assessment tool. So as you see, the modified MRC, this is the scale, starts with grade 0 to grade 4 and describes certain level of dyspnea. And the patient had to choose one of these. The CAT assessment it assesses the symptoms, and as you see, 8 parts. Each one has to answer with one answer, and then you collect the point, and you come to ABC assessment tool. When they started first did an ABC assessment tool, there was no spirometry involvement in this tool. Later on, they added spirometry, and they call it refined ABC assessment tool. As you can see, measuring symptoms by MRC scale. Measuring MRC and measuring CAT. MRC less than من 0 to 1 ولا MRC more than 2, that define the difference between the symptoms. Also the CAT less than 10 or more than 10. A, B, C, D. D is the worst because D as well as we have here the assessment of exacerbation is very important. If you have 0 or 1 not leading to hospitalization, that's usually A or B. If you have two or more, or 1 leading to hospitalization of exacerbation, that will be C and D. If you look at this, D will be the worst, because also on the grade of gold, 1 or 2 it will be under A or B. 3 or 4 will be C or D. So if a patient who is grade gold grade 3 or 4 with an MRSA more than 10, that will be within the D, with 2 exacerbation obviously or more. So basically this is a combined assessment, not based on this. They used to assess it COPD based on symptoms, based on COPD, based on spirometry alone. Now you can assess it based on symptoms, exacerbation, and spirometry limitation or grade. Here is the rule of spirometry. Either you can use it for diagnose, because you cannot diagnose COPD without having post-bronchodilator spirometry with reduced FVC ratio, as we said, less than 70, or assessment of severity of airflow limitation or obstruction for prognosis, or for follow-up and assessment, making therapeutic decision in selecting certain pharmacological treatment. When there is discrepancy between spirometry and level of symptoms, usually here I have to indicate to 1 point. And when there is discrepancy between symptoms and spirometry, especially when the symptoms worse than the spirometry, you may use high resolution CT scan to help you to assess the severity of emphysema, and that's very useful to look at. You will be surprised sometimes you have patients with significant symptoms. You do spirometry, you'll find grade 1 or grade 2, but the symptoms look worse really than the spirometry. You do a CT scan, high resolution CT scan, you will find significant emphysema on the CT scan. Also, spirometry can be used non-pharmacological assessment like interferential procedure, for example, prior to lobectomy, pneumonectomy, and other surgical-related procedures, and use spirometry to identification of rapid decline. Differential diagnosis of COPD. Differential diagnosis of COPD, as we all know, asthma, congestive heart failure, bronchiectasis, TB, bronchiolitis obliterans, and diffuse bronchiolitis. Having said that, asthma can happen even in an elderly patient. When we say asthma or onset early in life, it doesn't mean asthma doesn't happen in an elderly patient. So we can go through it and read the description, which we must all know of that. This is about quitting smoking, ask advice, assess, arrange. Here, vaccination for stable COPD. Influenza vaccine reduce serious illness and death in COPD patient. Add evidence B. Pneumococcal vaccine has been shown to reduce the incidence of community acquired pneumonia in COPD patient aged more than less than 65 years, with FEV1 less than 40, with comorbidity. In general population, adult more older than 65 years, the 13-valent pneumococcal vaccine has demonstrated significant efficacy in reducing bacteremia and serious invasive pneumonic disease. These are the commonly used maintenance medication in COPD, which start with beta-2 agonist, either short-acting or long-acting, anticholinergic, short-acting or long-acting, combination short-acting beta-2 agonist plus anticholinergic, SABA and SAMA together, combination LABA and anticholinergic in one device, LABA and LAMA, methylxanthine, combination of long-acting beta-2 agonist plus corticosteroid in one device, triple combination of LABA, LAMA, and inhaled corticosteroid, phosphodiesterase 4 inhibitors, and mucolytic agents. And inhaled bronchodilator is given on a regular basis to prevent or reduce symptoms, which is evidence A. So there's no doubt about this, the rule regarding the rule of bronchodilator. Regular and as needed use of short-acting beta agonist or short-acting muscarinic antagonist improve FEV1 and symptoms. Combination SABA and SAMA are superior compared to either medication alone, improving FEV1 and symptoms. LABA and LAMA significantly improve lung function, dyspnea, health states, and reduce exacerbation rate. This is evidence A. LAMA have a greater effect on exacerbation reduction compared with LABA, evidence A again, and decrease hospitalization. Combination treatment with LABA and LAMA increase FEV1, reduce symptoms compared to monotherapy. Combination treatment with LABA and LAMA reduce exacerbation compared to monotherapy. Tiotropium improve the effectiveness of pulmonary rehab in increasing exercise performance. Thiophyllene exerts small bronchodilator effect in stable COPD. This is evidence A. So thiophyllene really has a small bronchodilator effect and is associated with modest symptom benefit. This is anti-inflammatory therapy in COPD, talking mostly about all anti-inflammatory, saying that inhaled corticosteroid combined with LABA is more effective than individual component in improving lung function and health status and reducing exacerbation in patients with exacerbation are moderate to severe to very severe COPD. Regular treatment with inhaled corticosteroid increase the risk of pneumonia, especially in those with severe disease. Triple inhaled therapy, ICS, LAMA, and LABA improve lung function, symptoms, and health status, and reduce exacerbation compared to ICS, LABA, LABA and LAMA, or LAMA monotherapy. Oral glucocorticoid, long-term use of oral steroid has new side effect, evidence A, with no evidence of benefit, C. Phosphodiesterase 4 inhibitors, go on talking to that. Talking about antibiotic and long-term use of azithromycin and erythromycin therapy reduced exacerbation over 1 year. As we know, a study has been done on azithromycin, 250 milligram, one every other day for 1 year, and it shows it does reduce exacerbation over 1 year. But treatment with azithromycin associated with increased risk of bacterial resistant and hearing test impairment. So it should be done really in patients with intact hearing, with no hearing problems, no issue with QT interval and prolonged QT interval, and mucoregulator and antioxidant agent. Regular treatment with mucolytics such as N-acetylcysteine reduce the risk of exacerbation in selected patient. Simvastatin as anti-inflammatory has really no rule in COPD, but patient already been on simvastatin, there's no harm from continuing using that. Inhaled route, inhalation technique, we all know about how important to stick to right in inhalation antitrypsin deficiency, intravenous augmentin therapy may slow down the progression of emphysema. Antitussive, there is no conclusive evidence of benefit rule of antitussive in patients with COPD. Vasodilator don't improve outcome and may worse oxygenation. Pulmonary rehab, and it's important. Medication stress management, great. We have to move quickly maybe so we can get on the time with the presentation. This slide talk about the role of inhaled corticosteroid and which patient should be receive or better benefit from inhaled corticosteroid. As you see, the strong support in patient with history of or have more than 2 moderate exacerbation of COPD per year, or has blood eosinophilia more than 300, or history of or concomitant asthma. This type of patient, they strongly recommend to go and inhale corticosteroid. You should consider the use of inhaled corticosteroid in which patient? Patient with 1 moderate exacerbation of COPD per year or blood eosinophilia from 100 to 300. You should avoid use inhaled corticosteroid in patients with repeated pneumonia event with blood eosinophilia less than 100 or history of myocardial infarction. Palliative care and in-life and hospital care in COPD, use of opioid and neuromuscular elective stimulant, oxygen and fan blowing air on the face can relieve breathlessness, evidence C. Talking about in malnourished patient, nutritional supplement may improve respiratory muscle strength and overall health status. Fatigue can be improved by self-management, education, pulmonary rehab, nutritional support, and mind-body intervention. Here, the long-term oxygen therapy, we're going to come to that maybe in another slide. Intervention and therapy of stable COPD, Dr. Mohammed Ben Kayal, yesterday or last night spoke about rule of lung volume reduction surgery in COPD. And here's some evidence saying lung volume reduction surgery improves survival in severe emphysema patient with upper lobe emphysema and low post-rehab exercise capacity. Bullectomy in selected patient, bullectomy is associated with decreased dyspnea, improved lung function, and exercise tolerance. Lung transplant in severely COPD patient show to improve quality of life and functional capacity. There is bronchoscopic intervention in regard of volume reduction surgery in advanced COPD. Management of COPD, diagnose, as we spoke about, symptom, risk factor, spirometry, repeat spirometry if it's borderline, initial assessment, see what gold, FEV1 gold 1 to 4, symptoms, CAT and MMRC, exacerbation history, smoking status, alpha 1, if indicated to be checked, comorbidity, initial assessment with vaccination, active lifestyle, self-management education, manage comorbidity, and you keep going between these cycle to get your patient on the best shape. Goals of treatment to stable COPD, reduce symptoms and reduce risk. Reducing symptoms by relief of symptoms, improve exercise tolerance, improve health status. Reducing risk by preventing disease progression, prevent and treat exacerbation, reduce mortality. Identifying and reducing risk factor, exposure, smoking, efficient ventilation, and clinician should advise patient to avoid continued exposure to potential irritant if possible. Key point to use bronchodilator, as we spoke a little bit about LABA and LAMA. Anti-inflammatory, long-term monotherapy here not recommended. Statin therapy is not recommended for patient, not recommended for preventing or prevention of exacerbation. And here is the ABCD to help to apply the medication based on ABC as the assessment. Class A, as we spoke about earlier, with very low, with MMRC symptoms less than, from 0 to 1, with a CAT less than 10. This include A and C, B and D, MMRC more than 2, CAT more than 10. Then we look at the exacerbation, A and B 0 to 1, more than 2, C to D, plus the gold 1, 2, 3, 4 included. Based on this, you can choose your treatment: A, bronchodilator; C, LAMA; B, long-acting bronchodilator, LAMA or LABA; D, you have few options, either LAMA or LAMA and LABA, or inhaled corticosteroid and LABA. Cycle. This is again follow-up pharmacological treatment if you have, based on what's the main problem, dyspnea or exacerbation. If it is both dyspnea and exacerbation, you're gonna use the exacerbation algorithm. And you see where a patient is and put the treatment on the same in the table. You're gonna find, and you're gonna go with algorithm accordingly. As you see that the rule of azithromycin there, in if the patient or the exacerbation already in LABA, LAMA, and inhaled corticosteroid, and former smoker or chronic bronchitis, there's rule for macrolide here, as well as BDE4, phosphodiesterase inhibitors also come after LABA, LAMA, and inhaled corticosteroid. If the patient already in exacerbation, we're speaking about exacerbation. If patient on LABA and LAMA and still have exacerbation, you either go to add inhaled corticosteroid, or you choose adding azithromycin or phosphodiesterase inhibitor 4. This is non-pharmacological management, COPD. A, smoking cessation; B, C, D, smoking and pulmonary rehab. Here's when you describe home oxygen: arterial hypoxia defined as PO2 less than 55 or saturation less than 88, while PO2 more than 55, less than 60, with right side heart failure or erythrocytosis. You give oxygen and you follow up after 60 to 90 days to see if the supplement oxygen is still indicated or if prescribed supplement oxygen is effective.
Dr. Mohammed, we need to finish in about 5 minutes, please.
Almost done. Almost done. Differential diagnosis: COPD exacerbation, pneumonia, pneumothorax, pleural effusion, pulmonary embolism, pulmonary edema due to cardiac-related condition, cardiac arrhythmia, atrial fibrillation. Indication for non-invasive mechanical ventilation in exacerbation: at least one of the following: respiratory. I'm trying to cut it through so we can finish on time. Respiratory acidosis with the BCO2 more than 45 or pH less than 7.35. Severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breathing, or both. Persistent hypoxemia despite supplement oxygen therapy. Indication for invasive mechanical ventilation, you all know that. And I think that's the last slide. Intervention that reduce the frequency of COPD exacerbation: bronchodilator, LABA, LAMA, or LABA and LAMA; corticosteroid containing regime, LABA inhaled plus inhaled corticosteroid, or LAMA, LAMA and inhaled corticosteroid; anti-inflammatory non-steroid; anti-infective vaccine or long-term macrolide; macroregulator, N-acetylcysteine or carbocysteine; and various other like smoking cessation, rehabilitation, lung volume reduction surgery, or vitamin D. That's it.
Thank you so much, Dr. Sanusi, for an extensive review of the GOLD guidelines on COPD. I think we have one question, at least from one side. So with COPD, there is COPD is one of the it's probably the fourth or fifth leading cause of death in the world, But from your experience in working in Canada abroad, and also from your experience in working in Libya, what would you say the differences in epidemiological, uh, in terms of epidemiology of COPD? In other words, my question is, how frequently do you see COPD? Just as frequent as you've seen them abroad, or the matter is different?
I think the epidemiology is different between here in Libya and in Canada because in Canada they have applied rules of a smoking cessation where they stop smoking in public spaces, public area, and in restaurant and others that help to reduce the smoking by 40%. So which is decreased obviously in uh, in uh, in prevalence or in incidence of COPD. And on the other hand, in Libya, we don't really have a proper documentation to really study numbers and evidence prevalence. So to be honest, I can't say really how prevalent COPD because we don't have proper channel to document cases to to say the prevalence. Just by haphazard, I will say I see CBD in Libya more than I see it in Canada. But really, am I 100% sure? No, because I don't have enough data to study and look at to look at epidemiology in a proper way.
Thank you. That's quite interesting because we were talking about this last night, and we were wondering as to the feasibility of undertaking an epidemiology study here to look at the prevalence of COPD in Libya.
That would be, I think that would be very interesting to look at, and I will be very happy to be part of the study. And thank you.
Absolutely. So we turn to Dr. Hosnia. I think she has a question also.
Well, this question should be directed to the Gold Committee, not to me. No. But really, so far, the basic standard has been put in to be used to confirm diagnosis CBD is post-bronchodilator spirometry. Not all COPD will have emphysematous change on the CT scan. So if you do a CT, you will not see emphysema in the CT scan in those patients who hasn't developed emphysema yet, especially patients with chronic bronchitis more than emphysema type of COPD. So I cannot see that CT scan will replace spirometry in diagnosing COPD.
At least in this time, when the time of COVID-19 was
Well, go back, go back to history and physical science more than any CT. Plus the cost effective. CT will be costing very much on the patient. There's going to be cost issue regarding which patient can afford to do a CT scan and which can't. That's okay. Thank you, Doctor.
Thanks so much, Sanusi. Also, I would mention that Dr. Mohammed Sanusi has kindly been preparing the scientific content and would like to have a final word from the president of the Libyan Thoracic Society to an end to this conference.
Good afternoon, everybody. Thank you. I think in the second day of our conference, this Libyan Thoracic Society, we are grateful, thankful for all the speakers that they share us in this conference, and also thankful to all guests to us. Special thanks also for the member of the Libyan Thoracic Society. Thankful for the scientific committee by Dr. Mohammed Snoussi, and also the organizer committee by Dr. Isam Lakhdar and also Dr. Hatem Ashur. And thanks for the technical support by Dr. Mohammed Tikar. Thank you for all the members of the Libyan Thoracic Society, and we are looking forward in the next year that we have more events by this Libyan Thoracic Society, and also we looking forward that the 2021 will be better years than 2020. Thank you and good luck.